Well, good afternoon. We will get our presentation started momentarily. I'd like to introduce to you Dr. Benoit Dube. Dr. Dube is Associate Professor of Psychiatry at the Department of Psychiatry at the University of Pennsylvania. And he has been coming here to University of New England for several years in a row now. As everybody in the room, I think, realizes, we have this presentation at noontime, which is open to everyone and being streamed live to the Portland campus. At 1:30, we will be beginning an afternoon session on healthcare topics related to the gay, lesbian, bisexual, transgender population. I'll elaborate a little bit more on the history of that particular segment of our curriculum a little later. But I will turn this over now to Dr. Dube. Thank you very much.
Bear with me one moment. All right. It's a pleasure to be back in Maine. I grew up in Montreal, that's why I have a funny name. I went to the Université de Montréal for my medical degree, and now work at the University of Pennsylvania in Philadelphia. And it's an honor to have been invited for this talk. I was initially asked to come and do the LGBT Health Inequities Symposium this afternoon, and one of your peers asked if I could come in a little bit earlier to talk about a very important but slightly tangential issue, the whole mental illness / homosexuality quandary, which is really important because it is really at the core of the health inequities. If none of what I'm going to talk about had ever happened, there would be probably much less significant health inequities for gay and lesbian patients today because of a legacy of distrust and an ostracizing legacy that is the result of my kind. Psychiatrists. Psychiatrists are the reason for this. It's also interesting and very humbling for me to give this talk because the University of Pennsylvania kind of has an unfortunate role in all of this, and I'll share those details as we go along. This talk today is really about a story. It's a story of how a diagnosis appeared in a compendium of mental illnesses and the behind-the-scenes discussions that made the diagnosis change twice before it disappears. So here's what I want to do with you today. I want to convey to you that homosexuality was in fact a diagnosis in the Diagnostic and Statistical Manual, which is the compendium of mental illnesses used by all mental health professionals and physicians. And that even though it was removed in 1973, it was actually changed twice. And then, if you look at the DSM now, there are no traces of pathology associated with homosexuality, but it actually took 14 years, all in all, for that to change. I want you to also be aware that even though we don't, in 2012, talk about mental illness and homosexuality together in the same sentences, there is still a lot of pejorative and negative connotations associated with homosexuality, and that has to do more with the underlying faith-based underpinning of homophobia. And lastly, we'll go over why stigma happens and what the antidote to stigma is. So let's get started. The Diagnostic and Statistical Manual is essentially, to psychiatrists, what Harrison's textbook of internal medicine is to internists. Within the DSM is listed all of the mental illnesses that you can bill for. It's important that, to appreciate that there's an underlying business component to it. If it's not in the DSM, you cannot bill for services for a condition. So there's a lot of issues at play here when it comes to the DSM. The DSM didn't come about until 1952. At that point, it was very simple. There were two mental illnesses. You were either psychotic or neurotic. That's really all there was to it. So you either had impaired reality testing, that's psychosis, or if you had something else that was not related to impaired reality testing, then you were diagnosed as a neurotic. And then there's a whole kind of variety of neuroses that you can be diagnosed with. Everything at that point was based on psychodynamic theory, which is Freud and his understandings of the mind, with the ego, the superego, and the id. Well, we don't use these theories currently to diagnose mental illness, the theory behind it, the theory of mind that Freud has given us, is still very much alive today and relevant, but not diagnostically. Over the years, there have been many iterations, and in the spring of 2013, the DSM-5, and actually I realize now that's a mistake, they've gone from numerals to actual numbers, so it'll be DSM-5 as of the spring of 2013, and you may have been aware in the news that there's been a lot of controversy over what should be included and not included, notably Asperger's and autism spectrum disorders, so on and so forth. But let's, because I tend to go off on tangents a little bit, so before I veer off too much, let's stick to our target today, which is homosexuality and how it appeared in the DSM. In 1952, whereas prior to this, there was not an organized compendium of diagnoses, the first book that was published by the American Psychiatric Association lists homosexuality under psychopathic personality, and goes on to describe homosexual behavior or same-sex behavior as pathogenic and pathological. The understanding at that point is that there are assumptions of a homogenetic mother, so a mother that is too strong and that figuratively castrates her male offspring, turning him into a projection of herself and somehow giving her son her own sexual desires. Now, if you're having a hard time following this, it's okay, because I'm not sure I get it myself either. But that was the underlying understanding. But it is very important to remember that at that point, if you were gay or if you identified as gay, you certainly didn't want to tell anyone because you were considered to have a pathological personality. Like everything is wrong with you, the way you interact, the way you thought, the way you interacted with others, and it was listed as a sexual deviation. Now, that definition had 81 words and 3 sentences. As psychiatrists are trying to become a little more rigorous and scientific, along comes Irving Bieber, and in case you're wondering, there is no relation to Joseph. Irving Bieber was a military psychiatrist. In the military at that time, if you were suspected of being gay or found to engage in same-sex sexual behavior, you were dishonorably discharged. You were essentially kicked to the curb. It didn't matter if you were in a foreign theater or in active war, or if you were home on a base, you were just disowned by the military. As a psychiatrist in the military, Dr. Bieber actually thought that somehow there was something wrong with that. You can't just not do something for these poor people when they were mostly men at the time. So he, within the military, advocated that we should try to help these young men. He totally embraced the underlying psychodynamic genesis of homosexuality and tried to offer them treatment. It's important to note that within his military career, he entered the military as a captain, he exited the military as a captain, he was always turned down for promotion because he held these views that went against the establishment. It was the only paper really that tried to look at and understand what was going on in the psyche of homosexual men. So there were about 100 patients in this study that he collected from his peers, but it's important to note that all of the people that were studied in here were all under treatment. They were all either in the military or in prisons or in state hospitals. There were no quote-unquote normal people who were not in treatment. Based on the findings of Dr. Bieber, then everybody within the psychiatric community embraced the concept that if we can fix the wrongs done by the closed-minded mothers and the detached fathers, we can cure these young men of their homosexual longings, because it is, remember, pathological, it's a pathological personality. This was the basis for DSM-2 in 1968 that tried to steer away from the two diagnoses, psychosis and neurosis, to having a more fleshed out, more scientifically robust compendium of diagnoses. Remember that at the time, neurosciences were far, far less advanced than they are today. So the diagnoses that were in there compared to the previous were actually based on objective observations. So it was a step forward in trying to catalog abnormal behavior or dysfunctional behaviors. Homosexuality becomes a mental illness per se, so it moves out of a pathogenic personality, it becomes its own mental illness. It has its own code within the DSM. I think it was 302 or something like that. However, there is still a strong emphasis to sexual deviance. For whatever reason, being homosexual is equated with sexual behavior. Now today, in 2012, hopefully we all understand that there's more to one's identity than how they choose to express physical intimacy. However, at the time, it was really a very, very limited and simplistic appreciation of what made one's identity. Of note, homosexuality is clustered in with bestiality and transvesticism as having similar pathological significance. Now, this is when the fun begins. Remember, this comes out as 1968, so if you were diagnosed with homosexuality as a mental illness, then you must be treated. But because you are sick, and because you are, if you'll allow the expression, considered to be crazy, then it's okay for you to be fired, it's okay for you to be discharged from the military, it's okay for you to lose your housing, it's okay for you to be arrested and found criminally responsible because of sodomy laws, some of which still exist today. One of the treatments that was predicated was electroconvulsive shock therapy. So that was thought that if you rebooted the brain by inducing seizures with electric current, you could cure someone of their homosexual longings. Now, if that does not sound kind of harsh to you, then you need to come see me after the talk. Now, of note and of relevance to all of us is that if you were found to be gay, if you were diagnosed with homosexuality, you could not go to medical school. And if you sneaked by medical school or figured out during medical school that you were gay, you could not pursue residency training, especially not pediatrics, and especially not psychiatry. Now, let's take a step back and look at what's going on in the world at that time. There's a lot of political unrest. In New York, and I'm just picking on this as probably one of the more well-known occurrences, people are getting upset that there's something wrong about the fact that we're ostracizing a segment of the population that just isn't correct. In 1969, so a year after the DSM-2 comes out, there was a riot at the Stonewall Inn in New York, and essentially what was going on there is that police raids would specifically target that bar either for selling alcohol after hours, or they would have undercover police officers who would arrest two men who would be kissing, so on and so forth. And at the time, it was perfectly legal to do so because they had the backing of the American Psychiatric Association, because these people were deviants and therefore could be arrested. At one point, the patrons of the Stonewall Inn fought back, and they actually staged a sit-in and essentially started throwing things at the police. They got a little nasty. But if we look at the gay history movement in this country, it still remains one of the central events in terms of how the tide started to turn. Now, let's go back to psychiatrists. At the same time, gay men and women start thinking, well, you know, like I was an astronomer, I'm a Harvard-trained astronomer, and I got fired from the military. This is Frank Cameron who says this, who we'll hear about in a minute. Because that's not right. Like, we can't just sit down and take this. We have to organize and show the American Psychiatric Association that they are wrong. We need to show Dr. Bieber that while he meant well, like, he's created a lot of trouble for us, and he is making us sick. We weren't sick to begin with, but now through these policies, we're being ostracized, and we are being labeled as sick. So in 1970, the American Psychiatric Association meets for their annual meeting in the spring, and it's in San Francisco. So that's kind of like a toxic combination, right? So they meet in San Francisco, and many gay men, not just from San Francisco, but around the country, organize and storm the panels. They're very, very disruptive, but they're not very, very constructive. You know, they're very, very flamboyant. They have these outlandish outfits and they make noise. They disrupt things, they get attention, but they don't have a positive message to convey. They get attention, but they don't have information to lead to transformation. Now, they are totally out to get Dr. Bieber. Gay historians have said that he was referred to as the royal mother, insert that word. I'm not going to say it because it's being streamed. Like, if it was just between us, I would say it. But, Dr. Bieber, during one of his panels, is quoted as having said, "A homosexual is a person whose heterosexual function is crippled like the legs of a polio victim." Isn't that terrible? All right. So it's hard not to editorialize when you convey this material. It's kind of crazy. So, and I'm a psychiatrist, I can say crazy. So this is how this whole movement of change starts. It's 1970, it's in San Francisco. People are starting to pay attention. And within the American Psychiatric Association, you have to know that there was this stealth group within the APA of gay psychiatrists who were very, very closeted, because if they had been out, they would lose their medical licenses, they would lose the ability to practice psychiatry. So these stealth psychiatrists would come together and meet. There was no governing structure, because it is stealth, there's nothing on paper, and they were commonly referred to as the gay PA. So the gay PA members were happy about the disruption because they at least put it on people's radars that maybe we should reconsider this. There's something that is not quite right here. All right, next year, the American Psychiatric Association meets in Washington, D.C. At that point, they decide that they want to be a little more focused in their interruptions. So they don't just disrupt panels, but they actually have a message. They distribute leaflets, and they say, "Stop making us sick. But you need to reconsider the study on which you're basing this diagnosis. Dr. Bieber means well, but he's wrong, and he's full of baloney." Remember Frank Kameny, the Harvard-trained astronomer? He had been fired from the military because his supervisor suspected he was gay, and at the time it was perfectly fine to do that. And he was one of the people who, from outside of the American Psychiatric Association, says we need to do something about this. Notice that the leaders here are not psychiatrists, because at that point, if they say something, they will be fired. They will lose the ability to practice medicine and take care of their patients. The big issue here was, listen, Dr. Bieber's theories are pseudoscience. There is nothing scientific to support what he says. If anything, at that point, there's a study by a psychologist that says, wait, I want to see if I can replicate the Bieber findings in a cohort of non-pathological individuals, meaning individuals that are not in treatment. So she actually gets, I believe it's about 50 people. She gets 25 people who identify as gay but are not in treatment. They're just closeted because at the time you can't be out. But they're not seeking the help of a psychiatrist. They're not being medicated or getting ECT. She administers a whole bunch of psychological scales, and probably just to give in to Bieber and his people, she also administers the Rorschach test. The Rorschach test is an interpretive test that's essentially a blot of ink, and you're shown a very abstract-looking spot. And you're asked, well, what does this make you think of? And the assumption, or the premise of this test, is that you will express, through your interpretation of an abstract ink blot, underlying desires, so on and so forth. The psychologist that publicized this then had age and IQ matched controllers and subjected them to the same tests, gave all of this data to psychiatrists, and said, can you pick out the gay people in my group? Not only could they not pick out correctly who was gay and who wasn't, and they should have, right? If there's an underlying pathological personality, their Rorschach should be totally off the chart. It wasn't. Furthermore, the psychiatrists who were asked to evaluate this data said that 2/3 out of that cohort were actually very stable, productive, and mentally sound, which technically, if they followed their own guidelines, this sort of said that half of them were sick. That's how the questioning of the scientific basis of Dr. Bieber's work started. So we went from, oh, I can't say that because I wasn't even born. No, I was born. I wasn't born, and that's too young to do anything. So the movement goes from just gaining attention to actually asking questions. All right, the story moves forward in 1972, and they meet in Dallas. Now, Kameny and his friends think that it's not enough to ask questions. We have to tell people about the gay PA. But no gay PA members want to talk. They don't want to be fired. They organize a panel after a lot of probably arm twisting that has two civilians, a librarian and Dr. Kameny himself, the astronomer, and a psychiatrist. Now the psychiatrist is from Philadelphia. And this psychiatrist, who I'll show you a picture of, had been fired from the University of Pennsylvania Psychiatry Residency Training Program under the suspicion that he was gay. He actually said, you know I have nothing else to lose at this point because I've also been fired by the hospital, but I want to protect my dignity. I'm not sure that I'm willing or courageous enough to stand before my peers and be potentially labeled as insane and so on and so forth. So the compromise they reached with this psychiatrist was that he would be allowed to disguise himself and his voice. And he also didn't use his name. His name is actually John Fryer. I'll show you a picture of him. But he called himself Dr. H, anonymous H for homosexual, probably. He went out and bought a tuxedo, a very colorful tuxedo that was 3 times his size so that no one could guess his body habitus when he was out of costume. He also wore a mask. They wore a Nixon mask, which is interesting. They deformed the mask a little bit. They put a wig, and they also had him speak through a microphone that distorted his voice. This is what it looked like. He looks like a serial killer, really. However, and so this is Barbara Higgins. She's a librarian. And this is Dr. Kameny, who's fired from the military. They were really able to lead the gay PA to this moment because they could not lose any more than they had. But Dr. Fryer, who's hiding in there, the only way he would do it was like this. Now, every time I talk about this, I get choked up. Imagine that if you said that, you could get fired. And you have to dress up like a serial killer to say that. Now, maybe, I don't know how old you are, you think of this, you're like, that gets in the old times. It's not that long ago. And it's important that you know that this existed because the people you will be taking care of remember this. They might not remember this, the costume, but they remember what it was like to be diagnosed as mentally ill because they had true love and affection for someone of their own gender. Okay. Dr. Fryer, to his credit, gets a standing ovation. People are like, wow, I can't believe this. You sound so normal, you treat patients correctly, and you're a real person, and you're not crazy. So, this is Dr. Fryer. Dr. Fryer has since passed away, but he was really instrumental in getting psychiatrists to say, hey, stop thinking about those other people. I am one of you, and I'm totally fine. Yeah, I know, Penn fired me and all that stuff, but we need to change this. We need to take a stand and acknowledge that maybe with our best intentions we were wrong, that Dr. Bieber's study is flawed, and that we shouldn't propagate lies because we're hurting people. Now you'll notice that Dr. Fryer's wearing a Hawaiian shirt. I think it's just a coincidence, but for us it's actually really interesting because Hawaii is when everything comes together. Because in 1973, the APA meets in Honolulu. Now, in Honolulu, rather than just having a panel of gays and lesbians who talk about themselves in the first person, they actually gave Dr. Bieber and his cohorts the opportunity for a rebuttal. So they had, it was like the presidential debates. So they had on one side a panel of gay PA members and civilians who identified as gay and lesbian, and on the other side they had Dr. Bieber, Dr. Socrates, and a whole bunch of other psychiatrists who truly believed that they were doing the right thing and that they wanted to help people. Essentially, the gays won. So Dr. Bieber and Dr. Socrates were actually put to the task of trying to defend their theories, and they couldn't. And then there's this watershed moment when, after the panel, the gay PA meets at a gay bar in Honolulu. I don't know if it actually met at Hula's, but it's the only gay bar I know of in Honolulu. So they met at a gay bar in Honolulu, and one of the people that was there is Robert Spitzer. Robert Spitzer is a Columbia psychiatrist still today. And his relevance is that he was on the nomenclature board in the Board of Trustees of the American Psychiatric Association. As anytime there's going to be an addition or a removal of an entry in the DSM, the nomenclature board has to pass a ruling. Robert Spitzer was very intrigued by all of this. He was a young and eager academic psychiatrist at Columbia, and he had been part of that panel where Dr. Bieber was not able to support his theories. So he goes to Hula's, or wherever part of that actually was, and he's told the gay people, don't say a word, because if they know that you're here, then they'll figure out that you're spying on us. So you just have to like pretend that you're one of us. Pretend you're a member of the gay PA. Dr. Spitzer is not gay at all, but he was very curious. And he started to wonder, like maybe we are doing something wrong. Of course, Dr. Spitzer doesn't listen and starts asking all these questions. So then the gay PA people are really, really afraid. And then one thing happens. Enters a Navy captain in full uniform, who goes to Hula's because he'd followed secretly Dr. Spitzer, who he'd recognized from the meeting because he was on the board. And then he walks in and he says, that's it, I can come out now because I know that I have allies. And as the story goes, he crumbles into tears in Dr. Spitzer's arms. Dr. Spitzer was so moved by that, then a tall, very masculine-looking Navy person could actually crumble into tears into his arms because he was so moved about what he had heard on the panel. Dr. Spitzer said, you know what, that is the last straw for me. I need to bring this up for discussion with the nomenclature board, and in the fall, that's exactly what they did. They removed homosexuality from the DSM. Now, those of you who have followed this a little bit will often hear that it was in 1973 that homosexuality was removed from the DSM. That is factually incomplete. It is true that the line item homosexuality was removed, and if you go back, you will not find it, but you will find something interesting in its place. To appease everyone, because as you can imagine, it was like the Democrats and the Republicans. Everybody thought that they had the right solution to fix the budget, so they entered as a compromise to avoid the fiscal cliff. They entered sexual orientation disturbance. Now, while it is true that it is not homosexuality, it is a diagnosis that was entered as a substitute, a diagnosis that was reserved exclusively for homosexuals. So if you were straight, you can never be diagnosed with sexual orientation disturbance. You can only be diagnosed with that if you were gay. Well, so it's kind of like a watered-down diagnosis, if you will. The DSM doesn't change, it just has a revision, and that's 1973. 7 years later, sexual orientation disturbance is changed again, and it is changed to ego-dystonic homosexuality, which is actually, I think, a little more forthcoming. It is once again a diagnosis reserved for homosexuals. And ego-dystonic simply means that you are having issues integrating your homosexual longings with your identity. So ego is a sense of self, dystonic is meaning there's a discordance within you about the fact that you are gay. So once again, homosexuality is not a diagnosis, but it's replaced a second time by a diagnosis reserved exclusively for homosexuals. That's 1980. I'm not going to go through all the subsequent APA meetings, but there were lots and lots of panels. No one was wearing masks and costumes at that point. There was very heated, passionate discussion about what should happen. And in 1987, in the revised DSM-3 is when everything is removed. Homosexuality goes from being a psychopathology to just being a normal variant of human behavior. And that's 1987. That's not that long ago. You were all born, probably. But there's a legacy from that. And there's a legacy that you inherit. You've done nothing wrong. You're never part of this. But you will inherit the legacy of distrust that stems from everything that had happened up until then. Here's an example of this legacy. Is there anybody here who's going into pediatrics? All All right, so if I were to ask you, don't worry, I will not shame you publicly, this will not hurt, I will not embarrass you. Honestly, if I told you that I had a question about which guidelines you should follow as a pediatrician, would you follow the guidelines of the American College of Pediatricians or the guidelines of the American Academy of Pediatrics?
American Academy of Pediatrics.
Good, that is the right answer. So the right answer is the American Academy of Pediatrics is the professional organization that represents all pediatricians in this country. The American College of Pediatricians is a subset of pediatricians who disagree with psychiatrists who have removed homosexuality from the DSM. They disagree with their peers in pediatrics who have also said there's nothing wrong with your kids if they say they're gay. And they created their own professional organization that still maintains that you can prevent and fix homosexuality. Preventing and fixing homosexuality is referred to as conversion therapy. Very, very recently, the state of California outlawed conversion therapy within the last few months for anyone under the age of 18. You can imagine that in California there's lots of people who are angry about that because they maintain that either they've been cured themselves or they want the opportunity to have their kids go for treatment. It is an ongoing debate. Even though in 1987 we removed almost any traces of homosexual psychopathology in the DSM, there's still an ongoing societal debate as to what we should do. And Exodus has nothing to do with pediatrics. It has to do with a faith-based organization that has ads such as this that will offer treatment for young people who are struggling with their homosexual longings and urges. Within psychiatry, there is still a very, very active panel called NARTH, the National Association for Research and Treatment of Homosexuality. They are a part of the American Psychiatric Association, even though they're not officially recognized because they go against the official policy of the APA. They present every year at their meetings. Interestingly enough, they present an award called the Robert Spitzer Award. Remember Dr. Spitzer, who was the one who was very moved by that Navy person who started crying. So Dr. Spitzer in 2000 presented at the APA in New Orleans, and I happened to be present in the room. He presented data that showed that highly motivated homosexuals could change. So what he did is he got names and phone numbers of individuals that had gone to Exodus or other similar treatment centers, and he called them. He called them immediately after treatment, and he called them 6 months later, and his conclusion was that 6 months out, these individuals that had sought treatment, self-referred, still denied any homosexual longings, and his conclusion was highly motivated homosexuals can change. All right. The next day in USA Today, the headline is, gays can change. That was the headline. And I'm like, what? There's another presenter immediately after Dr. Spitzer, who was a psychologist, and you'll forgive me, I don't remember the psychologist's name. He had a similar data set that he followed people 1 year out, and he says, well, I don't disagree with what Dr. Spitzer found, but our data set that says that a year out, everybody goes back. So you can suppress these things, you can convince yourself that you don't feel a certain way for 6 months, but a year out after treatment, every single one in their cohort had come back. What does the media do? They don't present that. They just present gays can change, and they credit Dr. Spitzer for his finding. NARTH gives out a prize every year to call the Dr. Robert Spitzer Research Award or something like that. Now the irony to all of this is that Dr. Spitzer never ever said that homosexuality was a disease. He's the reason we removed it from the DSM. And furthermore, in the last few months, some of you may have noticed this, he issued a public apology in the New York Times saying, you know, I'm really sorry, my data set in 2000 was flawed, I should not have presented it, it was incomplete, I have done a lot of harm, I really am sorry. Yet, NARTH still presents this Dr. Spitzer Research Award. Okay, now, while homosexuality is no longer a mental illness, there's still a lot of negative press surrounding gays, lesbians, sin, morality, the foundations of society, the end of the world, and things like that. We've gone from a psychopathic personality with pathological sexuality to now a very unfortunate legacy of medical distrust and conversion therapy. But there's other things you need to know about in society that will impact your patients and that leads to health inequities. The issue of sin. This is what is quoted most frequently. If a man lies with another man as he would a woman, both have committed an abomination, they shall be put to death, and blood shall be upon them. And this is from the book of Leviticus, in the 18th chapter, the 22nd verse. People who base their dislike for homosexuals, who base their views of sin and immorality, often use the book of Leviticus. If your faith is very important to you, I am not telling you that you're wrong, I'm not challenging you, and I mean no offense by this. However, if you're going to preach Leviticus, you have to remember that means you can sell your daughter to slavery. That means there are issues about incest and putting people to death, so on and so forth. Like you can't just pick from Leviticus, which is a book of laws, essentially. You have to look at the big picture and put it in the right context. Having said that, the issue of sin for homosexuality is very much alive today. There are protests around the country all the time. This is my favorite, 3 gay rights, and this was, of course, contesting gay marriage, and this is an issue that Maine has finally seen the light on. Sorry, big editorial comment here, but yay, Pennsylvania, not so much. So 3 gay rights, AIDS, hell, and salvation. The Westboro Baptist Church is probably the most notorious. They will actually have pickets at fallen soldiers' funerals. Really, like, that's just so wrong. Like, you're allowed to shoot your opinion, but there's a way to express your opinion that is correct. But then, of course, this is probably my favorite, corduroy skirts are a sin. That's my favorite. And like, gay sex is in. All right. But then beyond faith-based organizations, there are still members of the mental health, professional core that will go on television or in print. And this was from last year when Chaz Bono, who is a male to female transgender individual, when Chaz went on Dancing with the Stars, there was someone on Fox News, it's just a coincidence, that said, don't let your kids watch Dancing with the Stars, because he went on to say it'll give your kids ideas that maybe they will want to, try this out to see if it fits for them. It doesn't work that way. Like, that's just wrong. So there are all of these messages, and then the church, whenever there's the horrific sexual abuse scandals in the church has incredibly managed to equate homosexuality with pedophilia. You must know as a healthcare professional that pedophilia is 90% heterosexual in nature. Most times, most occurrences of pedophilic behavior involve a man predator and a female or young woman victim. However, in most Americans' minds, pedophilia equates with homosexuality. Are there instances of homosexual pedophilia? Yes, but that's 10% of pedophilic encounters. We have to be able to see the forest from the trees when it comes to these things. Now, the whole issue of immorality and sin-based behavior leads to a lot of bad things for our patients. If you are 15 years old and you are living in a non-supportive environment and you hear all these messages, your parents watch Fox News and they see that feature, you see things in the newspaper, in church during the sermon, there's homosexuality is equated with pedophilia. Well, that doesn't help figuring things out when you're 15 because you get all these negative messages. And all these negative messages, and this is how it's relevant for healthcare providers, will turn into high-risk taking behaviors, will turn into delayed testing, will turn into delayed diagnosis. And this doesn't just affect the 15-year-old. This 15-year-old will grow up, whether he's a man or a woman, will grow up to become a 35-year-old who's more likely to drink and smoke and use drugs. And in the case of a 35-year-old woman, more likely to be diagnosed with advanced stage breast cancer, so on and so forth. That is the relevance of knowing all this stuff for all healthcare providers. It's not just a mental health issue. It started that way. But the legacies for all healthcare providers across all fields. Why does stigma still happen? Our mind is very, very simple. We are all wired this way. We are wired to see the world as us versus them, who is like us and who's different from us. You know how our immune system has the ability to detect self and non-self cells, right? The HLA antigens. Our mind is kind of like that, but it's a lot simpler. You look like me, then you must be a good person. You don't look like me, then I don't trust you because I don't know anything about you. And when I've met that one person who's different from me, whatever that characteristic may be, then I'm going to take these characteristics and apply them to everybody that looks or behaves like you. That's how stigma starts. We're very, very simple beings. We have to acknowledge that. Those are our first impressions. I'm not telling you not to do that, because it's not your fault. That's how you're biologically wired, as am I. But what I'm telling you is, when you make assumptions about patients, questions your assumptions, don't take them for granted, don't believe that you figured it out. Never be afraid to be curious about someone who is not like you. As a healthcare provider, make sure that your curiosity is driven by diagnosis and treatment, not by just curiosity. You're allowed to be curious, but there's different kind of curiosity that happens in your office than there can be when you're socializing with people. When we think someone is different from us, we tend to not like them because they're not as good or they're not as kind. Those are the assumptions that we make. We tend to make ourselves feel better by devaluing other people, by discounting what makes them different. And this whole, I hate to say it, but it's kind of tribal mentality. We are all wired. It's a survival skill that we've inherited from our ancestors, and that we can't fight biology, but you can try and get better control over it by being aware that it happens. And the underlying emotion, if we're going to break it down even further, is fear. Anything that is not like us, we fear the unknown, and that is why we make these generalizations. And I put that in there because I'm an HIV psychiatrist. Most of my work is done in an HIV clinic. And HIV stigma is very, 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 very present today. I know it's better than it was 30 years ago, but it's not over. There's a lot of disgust, contempt, and anger. People blame individuals who are HIV positive. You reap what you sow. So we have to just be aware that these things happen. That's why I put that in there. Now, homophobia is, simply put, a phobia or a fear of homosexuals, not of oneself. So it's an incorrect definition that we use. Homophobia is not restricted to heterosexuals. Homosexuals can have self-loathing as well. All those negative messages, all that legacy of distrust and homosexuality as a mental illness can be incorporated, and that's what's referred to as internalized homophobia. It is not uncommon for young men who are bullying gays in their community to later come out as gay men themselves. At that moment in time, when they're being bullied, they are struggling with longings and urges that are simply unacceptable to them. And the coping mechanism they use is reaction formation. So you take something that's unacceptable and you completely do the opposite, or you adopt a polarizing position. So if you're struggling with homosexual urges yourself as a young man, if it's simply, it doesn't compute and you cannot do it, then what do? Well, you beat other gays up to get rid of, symbolically, the homosexual longings that you have yourself. I'm not saying that all bullies are going to turn out to be gay, like that's a wrong conclusion, but it's not an uncommon trajectory for people who have this, and it is the most extreme manifestation of internalized homophobia. The basis of homophobia is fearing someone who's different from you, but it's also focused on sexual behavior. It's a very, very simplistic, oversimplistic definition of homosexuals by limiting who they are by what they do in bed. And that's just not how how we define heterosexuals. Like when we think of heterosexuals, we think of individuals in a loving relationship, who invest in a partnership, a lifelong partnership, who have children, who contribute to the community. We forget that part when we talk about gay men and women, when we adopt homophobia as our stance. I have good news, because it'd be kind of depressing if a psychiatrist let you down, or let you end the talk like on such a down and depressing note. So there is an antidote to all of this. The antidote to stigma is available to all of us, and we've actually seen this in the story that I've told you today. The antidote to stigma is communication. It's history telling, it's sharing. Dr. Fryer, that's what he did. He talked in the first person about himself, about what it was like, and he made other people realize that they were really alike, that they had a lot in common, except for a few things, and that made things okay. That is the antidote to stigma. That's why later today some of you will be joining me for a panel. We will hear from guests who will share what it was like to grow up as a little girl who was attracted to other girls, as a young man who felt that she was trapped in a man's body. It's by hearing stories that we can do away with negative ideas, with prejudgments, with negative assumptions. In a wireless world where everything travels at the speed of light, this effort to communicate and to share stories is a lot easier now than it was before. So you are, I'm sure, all familiar with the It Gets Better project, which was started in an effort to try and turn the tide on an epidemic of suicides in young LGBT adolescents. By having these individuals be able to access anonymously online stories of like-minded individuals who did navigate through the hardships of adolescence successfully, hopefully we can save a life by having that person access that information. So what have we learned today? Over the last 15 minutes or so, we've taken a little journey together, back to a time when mental illness was simple. You were either psychotic or neurotic. And one of the neuroses was homosexuality. Homosexuality was considered, up until 1987, pathological, whether it was an actual entry of homosexuality or whether it was modified to become ego-dystonic homosexuality. It only was in 1987 that there was no longer any traces of pathology associated with homosexuality. Because of that, there was a great legacy of distrust and ensuing health inequities that you will all have to deal with as health providers of tomorrow. Even though psychiatrists cleaned up their act, gay men and women continue to be the object of slander. The most recent election was not nearly as stressful as the previous ones had been. In 2008 and 2004, gay rights, gay marriage were very, very polarizing issues. Maybe because of the progress that's been achieved, notably in Maine, with this most recent election, the health inequities that exist currently will change. Maybe we are in the process of changing the tide and getting rid of inequities that will persist, at least for a few years, but maybe the next generation of gay men and lesbians will be able to feel stronger and not cave under pressure and make healthier life choices. You've been very attentive. No one has fallen asleep, which is very good. If no one has asked any questions, we have a few minutes. If you have any questions about anything I said, any thoughts you had, any stories you want to share. Yes?
If you have an adolescent patient and their parents are very against it, they don't believe in being gay, they want the conversion therapy, they think it's terrible, and this adolescent is kind of like, well, what do I do? What's the best way to handle that without being like, well, your parents are wrong?
So if an adolescent's parents think that being gay is wrong, what do you tell the adolescent and what do you tell the parent? So it depends what kind of doctor you are, or if you're just a friend of the family. If you're a friend of the family, you can say what's on your mind, and you're allowed to say this is wrong or this is right. If you are a healthcare professional, you have a responsibility to represent the position statements of your professional organization. If you are a psychiatrist and parents come to you seeking conversion therapy, then you have to counsel parents that it is not condemned by the American Psychiatric Association, the American Psychological Association, the Academy of Pediatrics, the social work organization also. Everybody has come out and said conversion therapy, not only does it not work, but it harms people. And you counsel parents on what you know, and you present them with the data. You will not change their minds, but you will be planting a seed, because when you hear the same message from other practitioners, maybe they will back off on the vigor with which they're recommending this. You also need to counsel the teenager and validate and support how stressful it is to be torn. We all want to please our parents, whether we admit it or not. And it's a very, very challenging position for the adolescent, and you need to foster in this young person the ability to create an alternate support network as a substitute or as an antidote to the stress that is being created. That's in a nutshell what should happen. These visits, they are not uncommon. Last spring, I had a mom from the Main Line. The Main Line is going to be very well-to-do area in Philadelphia, come to me because she was very, very concerned about her very effeminate young son. She thought she had done something wrong. And the visit turned out to be not about the son, but about her, because she didn't know how to deal with him. She had brothers, but they were nothing like her son. And so it often is about the parent more so than it is about the patient. Where's a hand here?
Along the same lines, how do you talk to, let's say, a colleague who, for example, might follow the American College of Pediatric guidelines?
So if your colleagues go against that recommendation, that's a little tricky. It depends what the bylaws and rules are at your institution. When you are credentialed as a physician in a hospital, you have to sign off on procedures that you are allowed to do based on the bylaws of the hospital. So at my hospital, as a general adult psychiatrist, I'm not allowed to see children because I'm not board certified in child and adolescent psychiatry. If I were to do something that either went against my credentialed procedures or something that is against what is supported by the governing body of my profession, then you can report that person to faculty affairs and sanctions will be taken. It is very rare that someone would do something like that. In a hospital, usually it is done as a private practice, and most institutions don't have a covenant. They don't let you have a private practice. They own your license, so every money that you generate has to go to the institution. If it's someone under private practice solely that happens to be a peer, you can report them to the licensing board in your state. And if it's in California, they can be arrested because of breaking the law. Yes?
So obviously being gay has been removed from the DSM, and that's improved or taken away stigma in that community. Could you just talk a little bit about gender identity disorder and how that being in the DSM could contribute or potentially hurt that community?
Okay. So gender identity disorder currently exists in DSM-4 text revision, which is the current iteration of the DSM. As you know, I mentioned very briefly, DSM-5 is coming out. And over the past few years, there's been a lot of talk about what to do with this diagnosis. Before we move forward with, because I'll tell you what's going to happen, I have to take a step back. So do we believe that it is a mental illness, it is a behavioral dysfunction to believe you are trapped in the wrong gender's body? Currently, according to the DSM, it is. In order to have access to hormonal replacement therapy, gender reassignment surgery, insurance companies today will require a diagnosis of gender identity disorder if the plan covers that benefit. As a psychiatrist, I refuse to say that someone is mentally ill so that they can get treatment. I've gotten it because I don't believe it's a mental illness. See, mental illness is a central nervous system dysfunction that leads to impairment. If you are struggling with the fact that you feel you are trapped in the wrong gender's body, that is not a central nervous system dysfunction that leads to impairment. It's a symptom that is a result of a biological anomaly or a biological error. That's what I think. So I'm not willing to put to paper that this person has a mental illness so they can get treatment. But I don't want them to be denied treatment. So the way I compromise with myself is that I will, rather than list the diagnosis, will actually list the symptoms. And I will say, I saw and evaluated Mr. Smith, Mrs. Smith, and based on my psychiatric interview, I can report the following. I will detail the symptoms, but I will stop short of saying this person has a mental illness. Because if I say this person has gender identity disorder, then they have a mental illness. So far, I have a perfect track record. It's never gone back to me saying as it's unacceptable. So my conscience is clear, my patients are happy, the insurance companies hate me, but that's okay. DSM-5 is also, the committee for nomenclature has also struggled, so what do we do? Because there's also a very, very vocal component of the American Psychiatric Association that says, is this really a mental illness? You know how homosexuality was changed before it was removed? I think that the same thing is going to happen because gender identity disorder in DSM-5 is going to be changed to gender dysphoria. Gender dysphoria is a symptom. It's very much like saying you live to stunning homosexuality, saying I'm struggling with something and I have a dysphoric presentation, I'm stressed out about it, I'm conflicted about it. So the next iteration will have gender dysphoria. The reason it has not been removed yet is because if we remove it, then we will withhold treatment from individuals who deserve to receive treatment so that they can have healthy and productive lives. Yes.
Do you think
So
that,
far, this side is what I mentioned.
do you think that the rewriting to gender dysphoric disorder is an appropriate compromise between the desire to not, and the importance of not labeling somebody who is transgender as mentally ill and the avenue for care? And if not, do you think that there is a better, what other better solution could you suggest?
So I'm very happy that the word disorder has been removed. Gender identity disorder just sounds like wrong. Gender dysphoria as a label, I can live with better because it doesn't imply disorderliness or illness. So I think it's a fair compromise. The reason why it can go away is because until insurance companies change their policies, the American Psychiatric Association would be guilty of withholding treatment inadvertently. So it's going to have to be a succession of changes. I think that gender identity disorder, as we understand it now, really refers to a variation of biological development. It's not a central nervous system dysfunction that leads to impairment. And as long as we agree on that, then that's how change will happen. And either we'll have to wait till DSM-6 or DSM-5 text revision or something like that, but the tide is definitely headed in the same direction. And if you look at it, it's exactly what happened with homosexuality. Like, it's just going to be a slow change, but it's definitely headed in the right direction. Now, in all fairness, some individuals who identified as trans will actually take issue with me and say, well, I don't care, you can call me crazy. Like, I don't care. I just want to be able to get hormone replacement therapy or gender reassignment surgery. I just want that covered. So everybody has different thresholds that they're comfortable with, is what you need to remember. Yes?
Can you just speak kind of generally about the DSM? And I know like homosexuality is the most infamous example of something being included that shouldn't be, but we just identified another one that's probably on the cusp of changing, and I'm sure there are others.
So when you think of the DSM, and I don't know if you learned about psychiatry yet, or what, so what you need to remember is that there are mood disorders, there are anxiety disorders, there are psychotic disorders. Like, that's really what the DSM is about for the general practitioner. And then there are more refined disorders under like sexual deviance, then there are disorders specific to children and adolescents. The biggest controversy now in the DSM is what are we going to do with Asperger's disorder? It's probably going to be changed to autism spectrum disorder because, truthfully, the data supports that. The data does not support having Asperger's disorder and autism as two separate disorders simply because the treatments don't differ. It's a very, very emotional issue. If anyone you know has been been diagnosed with Asperger's. I'm probably making you upset just talking about it, and I don't mean to. I'm just presenting what the nomenclature committee has decided. People like, when you have something that bothers you and someone gives you a label or an explanation, there's something very, very comforting about that. By removing Asperger's disorder as a separate entity from the DSM, we're removing that security blanket, if you will, from patients, and that's why it is generating a very, very emotional backlash. Now, final edition hasn't been printed. Who knows what's going to happen, but that's, like, maybe they'll storm the next panel of the APA in San Francisco next year. That's where it is. I'm not exactly sure what's going to happen about that. Then there are things like sexual addiction. Sexual addiction is not in there. There's talk about putting it in there. The funny thing about that diagnosis is, for as much as everything else has been cross-culturally validated, so major depressive disorder here is no different than it is in Europe or Africa because it's based on observable behaviors, sexual addiction failed that test because cultural norms are very, very different in different societies. So those are the kinds of issues that have come up with the next iteration of the DSM. I'm pretty certain that sexual addiction is not going to be put on there, but gambling may show up as a specific entity because treatment recommendations are separate for that kind of uncontrollable, intrusive behavior. So it's going to be like an offset of OCD, if you will. Does that answer your question?
Yes, I have a follow-up question.
Hold on, let me check with this side, and if, okay, let me take his question and then, okay.
I represent the side a little bit. I think that for some there's a unique challenge, particularly maybe in like older adolescents and college age homosexual males and females, in that it seems that sometimes the biggest bully is yourself, and that you don't realize the huge support network that you actually have, and that people will be accepting, and that what you often have to get over is this fear that you have yourself. How do you navigate that when treating?
Navigating the fear of one's own resistances is the trickiest part, and it's a battle that you have to fight solo. However, because you are aware that it's happening to your peers and people around you, the only thing you need to remember is when you create a safe space, and I'm using that phrase on purpose because UNE has safe space training, when you, and even as a practitioner, if you have a little rainbow flag in your office or if you have a rainbow caduceus on your lapel, when you give out cues that it is okay to talk about it, when that person who's struggling is ready, then they will know that there's a safe outlet. There's not just one way to come out. People come out when they are ready. And it is not true that you have to be out. You have to be out if you want to, and you will determine when that time is right. As an ally, you can facilitate that process by creating a safe environment, excuse me, by having a rainbow sticker somewhere or something like that that says, or literature in your waiting room that says it's okay to talk about it, because the message you're giving your patients is, if you want to talk about it, when you want to talk about it, I can handle it. That's essentially how we help them. Last chance. Okay.
So I think that there's been a trend in terms of defining psychiatric illnesses more in terms of functional impairments, as in you have this disorder, if you have this set of symptoms, and this set of symptoms interferes with your normal functioning. Am I right about that trend? When did that start? And do you think that that kind of helps with removing diagnoses that really aren't illnesses, or is that just not enough?
In order for, so everything that's in the DSM, regardless of whether we're talking about depression or schizophrenia, every single entry in the DSM has the behaviors listed above must lead to impairment. That is the common criteria to everything. If it doesn't lead to impairment, then it's not a disease or it's not a disorder. DSM-5, and I'll speak just in the first person, is a big disappointment for me because we know a lot more about the brain than we did when DSM-4 was trained and was written. Yet nothing is in there diagnostically. It's probably a very humbling reflection of how complex the brain is. We are not to the point where, despite all of the knowledge we have about amygdala dysfunction and PTSD, about the substance P anomalies, vitamin D anomalies, and depression, and I can go on and on. We are not to the point where we can make these diagnostically. I'll give you a very, very specific example. In the late 1960s, a cohort of psychiatrists published data that showed that individuals with major depressive disorder failed to suppress in the dexamethasone suppression test. So if you're not familiar with this, the dexamethasone suppression test is a test of potency for the hypothalamic pituitary axis. If you inject an exogenous steroid, the HPA axis, because of the feedback mechanism, sort of shut down, so endogenous steroid production should stop. That is a normal result for the dexamethasone suppression test. In this cohort of depressed individuals, they gave them dexamethasone and none of the patients suppressed. They continued to secrete endogenous steroids. So psychiatrists, I am sure, had like this big wild party because they thought, yay, we're real doctors now, we have a blood test, right? However, that cohort consisted of exclusively severely depressed patients with melancholic features, and some of them had psychotic features. That initial publication spread like wildfire, and there were many replication attempts, most of which failed, because if you broadened your cohort and had lesser degrees of severity, then they had a normal dexamethasone suppression test. The other issue is, maybe depression is 5 things. It looks like the same, but there's 5 different, maybe HPA in a dysfunction is one, maybe monoaminergic deficiency is another, maybe substance P is another. We're not there just yet. But that may explain why not everybody responds to SSRIs. It's frustrating because I wish there would be more, but maybe I just have to accept that there's not yet. But if you remember, anything in the DSM has as a common feature that there is impairment associated with the behavior. At this point, we're not sophisticated enough in our understanding of the brain to go beyond observable signs and symptoms to lead to a diagnosis.
We should probably give you a break.
Why don't we give me a break? I will get started at 1:30, but I'm going to stick around in the front if you have any other questions. Thank you very much for coming during your lunch break.
So this afternoon, we have an annual event here that I think everyone who participates will enjoy. We've had a session like this. This is the 3rd year that we've done this, and I'll give you a little history before I introduce our moderator for today's session. Several years ago, it was actually soon after I arrived here as Associate Dean, I was approached by the then newly organized UNE Club to discuss some curricular issues. And the issue they brought to my attention was there is not much in our curriculum about healthcare issues related to the gay, lesbian, bisexual, transgender population. And we had a discussion, the QMed people and myself, and where I had, the school I had left had a very robust curriculum that included a lot of healthcare disparity focus. And so I talked about some of the things we had done at another institution. And long story short, we looked at the calendar and it was just serendipitous, but when I looked for areas where we could perhaps insert some things that would be relevant, I found an afternoon where nothing was scheduled. It had to be the afternoon right before Thanksgiving. And so I said, you know, I don't know how this happened. I subsequently discovered there was a class scheduled and somebody couldn't make it, so they canceled it and nothing happened to the schedule. I said, well, we have time. We could get something in. What shall we do? And one of the members of the club happened to have a colleague at the University of Pennsylvania, and again, trying to shorten the story a bit, they communicated with each other and determined that there was a faculty member at the University of Pennsylvania that would serve our purposes quite well. It would be able to lead a discussion, kind of have a focused learning activity that would address the needs we were trying to address. And so we made some phone calls and emails, and then it worked out. And it was such a positively received learning activity that it was just a foregone conclusion that we would continue to offer this. So it's, in a sense, it's similar to some of the dynamics you've experienced before. I've built you folks up a lot, that you are an engaging population, you're an engaging audience. You know how to ask questions, you think through things, you are stimulated by things that challenge you. And so we have today planned out to be initially an address about some concepts and ideas, followed by a panel discussion, hence the chairs here and the water bottles, followed by an opportunity for half of you to break off into groups, which, to which you have been assigned. They're not your regular CBL groups. And you will go down the hall to the small group meeting rooms, and the other half will stay in here for some more discussion, and then we'll switch. Small groups come back here for that discussion, and the other half of the class goes out to the small group meeting rooms with facilitators. If you don't know which group you're in, I've asked Kristen to post some things along the walls. Maybe we'll get one on the door. Are they up?
There's one right out on the white door as you walk out, and then there will be like a small rooms.
Okay, so they're posted on the walls if you forget which group you're in. Hopefully you've had an opportunity to read the material that was posted associated with this class, because it should give you some orientation as to what we're trying to accomplish today, and hopefully be good fodder for discussion. So, our presenter today is Dr. I'll have to explain this. 2 out of 3 times I do this. Dr. Benoit Dube. But unfortunately, there is an author that I have read whose name is René Dubois. And you can figure that's why I get so messed up. I can't remember which name I'm supposed to be using. So Dr. Dube has been kind enough to come to the University of New England campus several years in a row now to conduct this class. And he is Associate Professor in the Department of Psychiatry at the University of Pennsylvania. And he can tell you more about his background as we move along here. But I would like to welcome him to our class today.
Good afternoon. Thank you, Dr. Dane, for a kind introduction. And on the topic of my name, so I'm French Canadian, which is why I'm called like that. But it's so funny because I often I get called Renoir, Dubois. When I go through customs, I get called Dube, Dube. And actually, I've had to grow used to living in an accentless world. So most of the time, my last name doesn't have the accent on it. But you're from Maine, so you're probably a little more closely connected to how Canadians do things. So thank you for having me again this year. I very much enjoy coming here because I feel like I've come home because of how things look. I grew up in Montreal and all over Eastern Canada. It's in the season of Thanksgiving. I'm very grateful to have this opportunity to speak to you all. And I wish when I was a medical student there had been such topics addressed as part of the mainstream curriculum, and to your predecessor's credit, we were able to do this. This is not rocket science. Like, you don't need to memorize enzymatic reactions. You're not going to be tested on this stuff in terms of the underlying biology, but I want you to have an experience today that will shape and hopefully improve the way that you can take care of patients. It's all about the patients. I know that. I learned that at the school. Dr. Dane gave me a nice little pin from my little college I get asked about back home all the time. And that's what this is about. This is about patients' journeys, patients' stories, and how you need to be aware that not everybody's journeys is the same, and it will impact the healthcare choices they make. It will change the way they choose to or not choose to share things with you, so on and so forth. So we have a whole afternoon planned for you. Overall, this whole afternoon symposium is really to give you tools so that you're more knowledgeable about sexual minorities. I want you to get a better appreciation by the end of the afternoon of the specific healthcare needs. We'll go over what the health inequities are in your LGBT patients. But most importantly, and this will happen in small groups, I want you to be aware of your own biases and assumptions. Now, there is no judgment inherent in that statement. is simply a statement of fact. I do it as well. We all make assumptions about patients. I don't want you to stop. That's just how we are. But I want you to stop yourself from taking your assumptions for granted and not verifying whether you're off the mark or not. That's really what this is about. Okay. More specifically, we'll talk about gender identity, sex roles, and sexual orientation, how these are part of one's identity and they are separate. We will talk about the fluidity of the spectrum nature, if you will, of sexual orientation. And for this initial seminar, we'll talk about identity formation in the LGBT population. Now, this is just to reiterate what Dr. Dane said. We're going to spend an hour and a half together. I'll talk a little bit, then we'll have a panel of guests. Then we'll break the class into two groups, half of whom will stay with me. We'll go over very specifically what the health inequities are, while the other half of the class has small discussions, and we'll switch roles, and then we will reconvene as a class at the end of the day to talk about what we've learned today. All right. I do want to acknowledge Dr. Dane for creating this event. This is the third iteration. And also the Queer Straight Alliance and their advisor, Dr. G. So Eugenia and Michael may be more familiar to you, and these are their predecessors in years past that helped make this happen. All right. Why are we doing this? Is there a reason why we're taking curricular time for this? So if we ask certain governing bodies, they will say very enthusiastically a resounding yes. The Institute of Medicine has issued a white paper on health inequities in gay and lesbian patients. The American Cancer Society has not said that there are different cancers for gays and lesbians, but has said if your patients are diagnosed with cancer and they identify as gay, lesbian, or transgender, you need to take care of them differently. The JCO, the Joint Commission that accredits hospitals, has said, because of a presidential edict a year and a half ago, if you do not offer visitation rights to same-sex partners, you will be deemed ineligible for Medicare reimbursements. The American Medical Association has had multiple position statements on the health inequities and the need for training at the medical level. The American College of Physicians has issued a textbook on the care of gay and lesbian patients. The American Association of Medical Colleges has said there is not enough medical education pertaining to this patient population. The national average is 5. There needs to be more. And this stems from work that was done at Stanford University. But most importantly, this is why we're doing this. The purple ribbon is a symbol of support for bullied teens who have thought of or attempted suicide. There were some very public cases a few years ago, which I'm sure you're all familiar with, because you must have identified with some of these individuals who were in the same age group, and some of you may have suffered at the hands of bullies or feared intimidation or being discovered or publicly outed in a shameful way. That's why we're doing it. If this symposium saves the life of one person, they would do a good job today. It was time well spent. Okay. First, because this is like postprandial lull, everybody's kind of falling asleep depending on what you ate, we're going to do audience participation a little bit. This is not to shame anyone, this is just to get the brain juices flowing and to highlight a point which I'll make afterwards. We're going to play gay, straight, lesbian, bi, or trans, or gay or straight, just to keep it simple. Who would like to venture a guess? Okay, so I will give you equivalent points for gay or lesbian, so that's fine. And so why do you say that with such conviction?
She's out.
Yep. So there's no guessing involved, everybody knows, and we're okay with that. What about this person? So there is no unanimous resounding answer. There's a lot of mumbling. Who would like to venture a guess and share with us what their initial reaction was when they saw this person? So obviously this person generated giggles and laughter. But if you had to peg this person as either gay, straight, bi, trans, what is the first thing that comes to mind? We all do. We all have an initial impression. So what is it? Like, I don't know if you can tell, but there's like a ton of hair product on this guy. Is there an association there that you're making, or maybe is there something about hand position, or is there maybe something about, like, that's a pretty tight t-shirt, he seems pretty well? Is no one going to raise their hand? Thank you.
His arms look like they're trying to escape from his cartoon t-shirt. Like you said, it's a tight t-shirt, the hair product. He's in good shape.
Nice teeth.
So when you put it all together, when you see that person, do you tend to think, I think this guy is gay or straight?
No. I don't really think one way or the other.
But when do you think he's hot? Like when you hit on him?
I think that maybe I'm not the best person to ask.
Well, then you can say no. You can say no, I wouldn't hit on him. You can say that too.
I feel myself.
So I don't. Then if I'm making
I'm a bad person.
what if I thought you were trying? Would you maybe feel a little like more courageous?
I might get louder.
Oh, there was a hand, but that was our technician. Oh,
I was going to help Jillian out. So
Thank you.
I'm like you. I wouldn't guess either way, but to go with the stereotype, he's a fine-looking man, therefore he must be gay.
Okay. Catherine, thank you for saying out loud what half the class was thinking. So thank you. And then you said something very important, which you said, I'm going to go with stereotype. Right? So we all make assumptions when we see people. Catherine's just a little more courageous than most of you. She actually said out loud what you were thinking. I would probably think the same thing, and if I were single, I'd probably buy him a drink. But the thing is, I don't know if he's gay or straight. They just cut out the picture from J. Crew. What about this person? Now this person, this is not a trick question. She's a real person. I'll tell you her name. I'll tell you her story. But what is the first thing you see? What is the first thing you think? So I did amongst them on Lindenhurst Street. Who would like to say where they thought that?
Come on, gang, be bold.
I mean,
Yes.
if we're going with the stereotypes, I mean, I feel like Ellen DeGeneres fits the stereotype of someone who's a lesbian. She has the short hair, she wears more masculine clothing, that's kind of a stereotype that we have.
And then from what we can tell here, there's no short haircut, there's a very feminine presentation with pearls. So then just quick judgment call, we would think this person is straight. Actually, this person is Guadalupe Benitez. She is a lesbian, and this is her and her family and her partner. So they have 3 children together. The reason I'm bringing up her story and her picture is she went for in vitro fertilization treatment because she was having trouble conceiving. This happened in California, and I forget where the rounds of injections that she was getting. At one point during casual conversation, she mentioned her partner by name, who happens to be a woman. And she received a letter from the practice saying that they could no longer offer her treatment. She was 5 injections into a 7 injection cycle, and they denied her care because they could not condone her behavior because she wanted to conceive and have a child with another woman. So she sued them, and she said, well, that's not right. Like, you've taken tens of thousands of dollars, and now you're just going to stop. Like, that just doesn't seem right. You're discriminating. And the Supreme Court of California ruled in her favor, and they deemed that there was discrimination based on sexual orientation. Now, I purposely picked her because you said out loud, kind of like what Catherine did, we make a quick judgment call when we see people, and that's not wrong. Like, I do it, we all do it, and I don't want you to stop doing it, because these judgment calls help you determine whether you're in a safe situation or a dangerous situation. So it's instinctual and adaptive to do so. However, we get in trouble if we make assumptions, and the fertility clinic got in trouble because they just assumed she was a straight woman because she was seeking fertility treatment and never bothered to ask her. And when they found out, then they said they deemed that it was inappropriate for her to start a family. Obviously, they were proven wrong, and so she ended up having twins. So that is Guadalupe. What about this guy? So he's a real person as well. Anybody from California? Who said gay over there? Do you want to tell me why?
The slick back hair, the fine dress.
So there's something about the way he presents. He's very proud of his appearance. Is it no one from California? Because he used to be the mayor of San Francisco. So if I tell you this person used to be the mayor of San Francisco, if I told you this person championed same-sex marriage and made it into law, would that change? If you thought he was straight initially, would you be more likely to think he was gay? I mentioned that to you because, so this is Gavin Newsom, so he's now the Lieutenant Governor of California. He, at the time, was the mayor of San Francisco, and he said, well, that's kind of silly. Like, why can't gay people get married? In my city hall, same-sex marriages will be allowed. And then we all know how that story ended. But I bring up his picture because sometimes, not because of how people look, but because of people's beliefs or behaviors, we make assumptions about them as well. So many people thought that he must have been gay if he was championing same-sex marriage, because like, why else would he care? So assumptions are made not just based on appearance, but they're also made based on people's behaviors and beliefs. Don't stop making them. Just catch yourself when you are, and never assume that your assumptions are correct. Now, if you've not read this book, it's an easy read, and it's actually a lot of fun, and it highlights these pattern recognition decisions that we make. Now, you guys are professional students. You've been in school a long, long time. And if I were to show you a 2-minute videotape of a college professor, you, because of your experiences, would be able to predict that college professor's teaching evaluations because of your experiences. When we see individuals that are not like us, we unfortunately generalize based on a limited sample and make the same quick judgments. And that's what happens for this segment of the patient population. Now, just so that we're all on the same page here, you're going to get a lot more information about this in your small groups. I say LGBT today just because it's simpler and it kind of rolls off my tongue, but a lot of other words have been used historically. The term homosexual, just this is an interesting historical factoid, is actually the operational definition of a male rodent who adopts a lordotic position. So it's like a guy rat who raises its hind to receive copulation, which is usually what the female rats do in the animal kingdom. And this was a Bulgarian biologist who was doing these hormonal manipulations, and when his male rats would be in lordosis, that male rat was considered to be homosexual. It's very interesting that today, the word we use actually comes from rats who would lift their hind, but that's where the actual word comes from. Historically, the word gay has had many iterations until today. Queer was used, which technically means strange or bizarre. It was used as a term of empowerment for a minority that was ostracized. The word gay was used as a reaction to they were not strange, they were actually quite happy. Back in the time during the McCarthy era, when it was dangerous to be gay, and some of you who were here over lunchtime know that you could actually be diagnosed as being crazy. It was a mental illness at the time. Friends of Dorothy became a code word for gays and lesbians who did not want to be unmasked on the cover because at the time you could be fired, you could lose your medical license actually, and you certainly would not be invited to practice pediatrics or psychiatry. Queer comes back as a term of empowerment. This is in the HIV/AIDS epidemic at the very beginning. LGBT shows up as a very politically correct term, and the alphabet soup has expanded to include lesbian, gay, bisexual, transgender, queer, questioning, or intersex individuals. If this alphabet soup is a little confusing to you, I would invite you to discuss this with your peers during small groups this afternoon. Okay. Now, we also use the term gay in this day and age as a slur. Mostly teenagers do that. And let me do this, because I forgot to plug the code section. I'm going to sit down so as to not block your view, but I'm sure it's okay.
Don't say that something is gay when you mean that something is dumb or stupid. It's insulting. this pepper shaker was stupid, and I said, man, this pepper shaker is so 16-year-old boy with a cheesy mustache. When you say that's so gay, do you realize what you say? Knock it off.
It's important to realize that the term gay is used as a slur, even though technically what I'm trying to convey is that it is a component of one's identity. And just to dive into the social sciences and behavioral sciences for a few minutes, one's identity really has multiple components. It has to do with how you view the world, how you experience interactions with others, how you view yourself, your place in society, how you feel. That's really what identity is about. It's not just about sex. It's not just who you're attracted to. It's about how you conceive of yourself. If we break it down very systematically, there's actually three components to one's identity: gender, sex, and sexual orientation. And multiple permutations of this define who we are. Gender identity is usually pretty much decided by the age of 3. And we know that by looking at drawings that infants will make. We know that by the choices infants will make when given the opportunity to choose between different toys. We know they will use different colors, they will draw different things, so on and so forth. Sex roles is a culturally determined component of identity. So as a young boy or as a young girl, you will, because of your environment, incorporate different expectations. As a young boy, soon to be a man, I should behave this way. It is socially normative for me to do this and not that. And of course, there's a similar process for women. And lastly, sexual orientation, regardless of what happens beforehand, is who you're attracted to. Who are you attracted to physically? There's physical intimacy, but there's also emotional intimacy. When we talk about someone's identity, we're just not talking about their behavior, we're talking about who they want to be with, not who they want to have sex with. Because you can identify one way, but enjoy sexual activity different ways. The two do not necessarily predict one another. It's important to not make assumptions yet right here. Now, if we look at vocabulary or words used to expand on these concepts, sex is determined biologically, hence we use male or female, but there are biological conditions which you may have learned about or will be learning about that aren't so clear. So there is a spectrum, even within biology, where you can have intersex individuals. When it comes to gender or cultural expectations, some people actually don't have clearly defined black or white males, so we can use human as part of the spectrum of being or seeing oneself as a man or as a woman. In terms of masculine and feminine, there's also androgyny, either by choice or by defiance. And lastly, who you're attracted to is also in a spectrum. So Kinsey, you may have heard of the Kinsey studies on human sexual behavior. Kinsey said that 30% of men can actually have sexual contact to the point of orgasm with another man at one point during their life. It doesn't mean that 37% of men are gay, because the 63% of men were like freaked out by this data. It just means that sexual behavior is on a spectrum. You have to recognize that, and also never extrapolate from behavior how one perceives oneself. Identity development is pretty straightforward, no pun intended, for most people in the population. Right? So you grow up, you think you're a little boy, you look up to daddy, you buy like metal hammers and construction kits, and you emulate his behavior, you start dating girls, your sexual feelings, all confusing and overwhelming when you're an adolescent, are validated in movies, books, on the news, everywhere. So you overcome that struggle and you become like a just a normal, well-functioned heterosexual man. And then you can fill in the blanks for women. However, if that little boy is struggling with same-sex longings, it's not that easy. And that's why identity development is a little bit more challenging for our LGBT patients who have struggled many times in silence. Retrospectively, when we've asked adults about what it was like for them, every single person will say, I didn't have the vocabulary to say it when I was 8 years old, but I knew that I felt differently. And we've asked adults over the last 20 years about this. It would be interesting if we were to ask prospectively children now. We do know that sexual experiences tend to happen earlier now than they did 20 years ago. We don't know necessarily about the vocabulary. What is clear in the literature is that safe outlets and support groups are more readily available. So part of the population is doing much, much better about this, but it doesn't mean that our work is done. There are still parts of the country where there are negative messages that are conveyed in schools and in churches, and we have to remember that one day these adolescents will be our patients. This comes from the pediatric social work literature. It's a model that was espoused by Croydon, and that's pretty much been adopted by everyone in healthcare. The LGBT development that leads to coming out essentially has 4 stages. People feel different before puberty. Either they have the language or they don't, but they just know they're not like their peers. During the identity confusion, during full-blown hormonal surges, now that's confusing for everybody. However, for LGBT patients, there is no validation. There is no one to look up to. There is not an older brother or an older sister or cousin who can say, no, that's okay. Like, there's no one whose behavior you can emulate. That's why the identity confusion is a little more challenging. And that's the riskiest part of all of this, because that's where bullying is very detrimental. That's where there are suicide risks. And we'll go through the health inequities later. I'll flesh out even more so. There are specific segments of this population that are at greater risk for self-harm behavior. Most of your LGBT patients will navigate this successfully, and that is called identity assumption. But that's usually when you have, like, you're out to a friend or two, and then the wider that circle becomes, the bigger your safety net is, then that's what is called the commitment phase, while you're out to your family, your coworkers, so on and so forth. Coming out is the expression that is used to describe someone who comes to terms and accepts their same-sex longings for physical and emotional intimacy. There is a National Coming Out Day that happened in October. I don't know if it was celebrated here, but there are more and more safe outlets now for people to express this. The ostracism that used to exist is no longer as bad as it was, but it still exists in homes, churches, and other social groups. Now, just to give you a preview of things to come, you may think that, oh, like it was, he's old, like it was like that for him, it's not like that for us. And you're allowed to think that, not that way, by the way. But you need to think that this isn't about you as much as it is about your patients. You need to know about this stuff so that you can take better care of your patients who may not have been able to navigate this successfully. You need to be able to ask the right questions. You need to be able to create a safe environment where patients will be able to volunteer things that they can't at home, at school, or in church. There's a legacy of distrust that all healthcare providers, you included, must unfortunately shoulder. Homosexuality was a mental illness until 1987, and all of your patients who have been through that time, when psychiatrists could diagnose someone with homosexuality, which would result in a stain on your insurability, loss of jobs, so on and so forth. You need to know that you will be taking care of these patients. Going back to how this whole thing started, never make assumptions, or never mistake your assumptions for your truth. You will make snap judgments through pattern recognition on all of your patients. I don't want you to stop doing that, but I want you to not stop there and test your assumptions to see if you are right about your patient's identity, patient's behavior, and that the two don't necessarily predict one another. All right. The best way to learn about this stuff is not to necessarily memorize lists of questions, but is rather to hear patient stories, because you will remember patient stories when you take care of people like them in the future. We're very fortunate today to have 4 panelists who have agreed to talk about themselves to an auditorium full of strangers. And actually, I don't know them, so I will invite 4 panelists, Steve, Jill, Maya, and Brian, to join me at the front. And please welcome them.
And I'd like to ask you, should have asked before, please close your laptops just to minimize the distractions.
you're going to be that name holder. Press the button on the left on the bottom until it turns green. And then the little screen will turn green. Keep your finger out. And then you get one to shirts. Okay, so we have one mic that we share, and we will share them with Kyle. It'll just really for the camera. So since I've never met you before, I actually don't know who's maybe one person I recognize from last year. So if you could introduce yourself to the class, just tell us a little bit about who you are, what brings you here today, and then we'll lead you into that one.
Okay, so my name is Jill Barkley. I am 31. I identify as a lesbian, and I live in Portland, where I've lived for the last 8 years, and I'm currently partnered to a woman named Trish. And I'm really excited to be here today because my late sister was a surgical resident at the Brigham. And so I have a really special place in my heart for med students and for residents. My brother-in-law is also a doctor, so I've spent a lot of time. I felt like in undergrad, I felt like I was almost in med school because I hung out with my sister and my brother-in-law, and they're friends so often. So I'm just really excited to be here with you all today. I think it's great that we have this opportunity to talk about this topic and the ways that you can improve your future care of patients like me.
Thank you.
Hey, my name is Maya Tavares. I'm 28 and a pre-med student at USM. I want to become a physician in order to work with transgender, genderqueer, gender variant people to have better experiences than I did, and so that's another reason I'm really excited to be speaking here in this room today. I'm transgender identified, but for me that doesn't mean what I think is often represented about transgender experience, where like I was born one way, I went like all the way down a super straight road to another super straight, clear, identified thing. I stopped transitioning 3 years after I started medically transitioning, and so I live in an androgynous place where trans for me means like transcend, transgress, and we'll get into more of that later.
Hi, I'm Steven. I'm 31. I also live in Portland. I was born female and I identify as male and have been living as male for 12 or 13 years now and have been on hormones for probably 10 of those years. I'm partnered to a man. I've been in a relationship with him for a year. I work as a nanny. And I did this speaking engagement last year, and I was really impressed with how receptive the folks were last year to being better care professionals for their patients and how many great questions they had. So I was excited to be asked to do it again this year.
Hi, my name is Brian Baudet. I'm an architect, and I'm a gay man. I have 3 kids, very wonderful kids. I was actually in the closet until about 2 years ago. I actually came out to my wife 13 years ago, so we kind of had to grapple with that during the marriage. I am honored to be here. I was a pre-med student at Boston College. Took a different route to become an architect, but my brother is a cardiologist, and mom's a nurse. My wife was a nurse. I mean, medicine is definitely in my family. So I respect the course that all of you are taking. I have the enormous amount of respect for people who go through to the medical field. I know how difficult it can be.
Brian, grab the mic, and then you can share that with Steve.
Sure.
All right. So why don't we get, with the one striking thing is that Maya and Stephen, while you both identify as trans, it seems to mean something very different for both of you. I wonder if you could help us kind of better understand the labels and appreciate what we need to understand as providers. If we were to say you, Maya, or you, Stephen, like what's different for us?
What's that? Yeah. More comfortable this way. Well, I mean, yes. The short answer is yes. There's a lot of ways to have a gender. I mean, when I look out here, like I think I see a lot of people who maybe identify as male or maybe identify as female, and one person might work their gender in the way they identify that way in a totally different way than another person in the audience. Like gender is an individualized expression and experience, regardless of whether that gender is a transgender or that gender is a binary cisgender. And when I say cisgender, that's a term that a lot of trans folks use and a lot of queer folks use that's kind of starting to ripple out, meaning, y'all have had a lot of biology, like unchanged, right? So like your biological sex and your concept of gender are the same. So that's the first thing that strikes me about that question, is that no two transgender people, regardless of whether I identify as more gender ambiguous and Stephen might identify a different way, that's just more of like a polarized representation of differences in gender, but everybody has a difference in gender.
I don't really have much to add to that. I think it's a great explanation. I think for me it's different in that I don't necessarily identify as transgender in my everyday life. Like the folks I work for don't necessarily know that I'm trans, some do, some don't. In the medical community, I found I've had to come out because most people see me and assume that I'm a guy, and I've always been a guy, and that's run into some issues when trying to receive medical care. So just, I guess for me, it's affected me in the way that I have to gauge like how safe I am in a doctor's office, or if the doctor's office I'm going to might have had experience with trans people before, or may not have, and that's just something I don't have to think about anymore because I've been on hormones for so long.
May, when you talked about your journey, you said, I stopped transitioning. So is it that you were headed to the final destination, and then at one point you said, I'm comfortable where I am now? Is this something that is fixed? Is it something that can change in the future? Because it's very different than what you've heard from Stephen.
Okay. I think that it's awesome that in our culture we're starting to get more trans narrative within our popular culture awareness. That trans narrative is very, very often very, very binary. And heads from one fixed point to another fixed point, and that is not my experience, and that is not the experience of many trans people. I find like one of the most common questions I get asked when I come out to somebody is, oh, you're trans, have you gone all the way? And like, they want to know what my body is, they want to know what surgeries I've had, and they assume that because I'm trans, I'm headed in a linear place to an end point, and that has never been true for me. When I stopped transitioning, it wasn't because of a personal truth or a personal happiness with where I was. It was because in part of not receiving competent care and having very little faith in the recommendations that my physician and that the people I had access to were making for me. I started transitioning when I was 19 years old. And for me, transition meant being on full-dose testosterone. And I had a radical double mastectomy when I was 19 as well, which is awesome. And then by 22, I was experiencing a lot of pain in my body, a lot of very extreme fatigue, and was being put through a regimen of tests for different types of reproductive cancers. At which point it was recommended that I have a hysterectomy. Now at 22 years old, that's a big decision to make when you're still kind of figuring out, well, is this, if I do this, like you're all aware of repercussions of changing like a dominant organ in your endocrine system. Is this going to change? Is it going to put me at heightened risk for XYZ, so young? This means I'm, constantly going to be supplementing the dominant sex hormone in my body artificially. And if that, for some reason, either can't be testosterone because there's a shortage, because I'm out of the country, because it's a controlled substance, or because I don't want it, I will never pay for estrogen. Like, that is like the biggest irony for me. And so I would, and I also, at 19, when you transition, you sign a paper that says I am making an informed decision that I am functionally sterilizing myself. I'm of sound mind to make this decision, and I accept that this is going to have serious consequences in my reproductive future. And at 19, I was like, yes, you know, like, and at 22, that was very different when faced with, you know, 2 weeks out of the gate, I'm going to have this surgery, and I'm not going to have a chance to ever produce a child that is genetically mine. And at 22 years old, I was like, no. And I decided that that was a decision that I felt differently about, and that I couldn't have had that kind of clarity about until I was, you know, 2 weeks out from, like, endgame. And so I made a decision to not have a hysterectomy, to come off of testosterone, to heal my body in the ways that I knew how to stop the pain and stop the fatigue, take a lot more control over my own health, because seriously, 22, what, that's 6 years ago, there's not a lot of education around even basic trans care, let alone what happens when something goes wrong. They're like, oh, you're trans, great, 100, you know, 100 mils of, not 100 mils, it was a mil, whatever, it was a long time ago, doesn't matter. This dose, this many times, great, have fun, we'll monitor your levels. You're at a standard male, great. That's the extent of, like, F to M, as they would call it, care that I received. When I'm like, I'm having this thing, and this thing, and this thing, and they're like, no, take it out, you know? And I was like, no. And so, because I want to carry a child in my life, that's a cool thing my body can do. I know how to take care of myself. I stopped everything. I didn't tell my doctor because I didn't have a lot of trust in her abilities in the first place. I was pretty alienated from care. I took care of myself. I felt fine in a month, and I've been kind of living and walking it ever since.
You shared your journey with us, and I gather that, Stephen, you've had a journey that's been protracted as well, or was it clearer for you?
What was the last one?
I was just trying to compare and contrast your journey with that of Maya's.
Yes, my journey is similar. In fact, I knew Maya when we started transitioning, and started transitioning around the same time. I haven't gone off hormones and have undecided whether that's something I'll choose to do or not in the future. I think at this point in my life, regardless of my decision to be medically transitioning or not, I feel confident in saying, like, I identify as male and see myself always identifying as male and don't see that changing. I think what's changed for me over the years is that the further along I've gone in transition, like, I feel much different about myself at 31 than I did at 18, 19, 20 when I was figuring all this out, and at the time was started identifying as a lesbian, then started identifying as a straight man, then started identifying as a gay man, and all this transition for me was intertwined with my medical transition because I never felt comfortable in my own body or with my own self. As like an 18-year-old boy who didn't look like a boy or looked like a 12-year-old boy. And for me, it wasn't necessarily about, like, I think you hear a lot of the narrative of, like, I was born in the wrong body, or like trans people must be so tortured because they've had these like terrible hard lives. Like, I've had a really great life, and I know so much more about myself now than I think I ever could have had I not gone through this, and feel so much closer to my family and the people around me than I would have otherwise. So I've seen it as a blessing, and I'm going to keep going on this path, so it's working out so far.
Now, so you said at one point I wasn't sure, was I a straight man, or... So Brian, I wonder if you could speak to your experience with labels, because you've also had a very interesting journey as well.
Yeah, I think I knew something was different about me from a very early age, as far back as probably 5 years old. But it was very confusing. There was nobody to talk to about this issue. I was raised in a very strong, strict Catholic family. So I just kind of knew there were no options for me. I mean, I didn't really think of other options. This was the way it had to be. And then, of course, then when I was in college, that was 83 to 87, that was at the height of the AIDS crisis. And sex with men equaled death. I mean, it was as simple as that. So, and I actually enjoyed dating girls, women in high school. I'm very passionate. It wasn't so much the sex. It was the kissing, the hugging, and so it added to the confusion. You know, I really didn't know what I was, and you know, and of course, I was being swayed into the direction of being straight from a social point of view, you know, and health-wise. So, you know, I ended up marrying my best friend at the time, and she's a wonderful woman. I still love her dearly, and you know, it was something that I went into the marriage thinking that I could endure for life. It was a commitment that I took very seriously, and just a number of bouts with depression and the dynamics changing within the marriage once we had kids kind of made it pretty apparent that I wasn't happy, and as a result, neither was my wife. So back 13 years ago, I knew it was very important for me to you know, disclose this part of myself. And then the other thing is that, you know, here I am living with this wonderful woman, and she loves me, but she doesn't really know me. You know, she doesn't know this deep secret that I've been keeping my whole life. Nor did anybody else in my life, you know. So, you know, how do you really feel loved at that point if what people are seeing isn't really who you are? So I went to her, and it was probably one of the most difficult times of my life, even to this day, was I ended up presenting her with a letter that I had thought about for, I think it took me 2 months to prepare. And I brought up the issues of, when we were in college, we had both taken sociology classes together. Not together, she went to UVM, but we were discussing the Kinsey scale. And she's sort of, you know, she's not completely feminine. We were kind of proud of the fact that we were sort of the androgynous couple. And we had an early discussion about how we felt like we were somewhere on the scale of the Kinsey scale, and certainly on either end of it. So I felt like, you know, that was a lead-in. So I kind of went with that in the letter, and thinking that, you know, it would be okay, and it wasn't. The world fell apart around us. We had 3 young kids. And it was one of the most difficult times of my life, but we just kind of swept it under the rug, and just knew we had to survive with the kids, and just didn't deal with it, you know, until 5 years later when I had hit another bout of depression. I really, and the other part of this too was that I had no friends. I had no male friends that I could speak of, and it really bothered me. I'm a very, very social guy. And I couldn't understand why I couldn't bond with other men. And God knows I tried. But I think what it came down to is that I wasn't looking so much for a best friend, I was looking to be intimate with another man. So I was looking for something far more deep than I think just a best friend could have offered. And I think when I finally came around to that, that's when I realized I needed, you know, to move on and leave the marriage. Everything, you know, and it's been 2 years. It's, you know, still in the middle of the divorce process, so it's still tough. But I'm in a much better place. I can't tell you. I've never been happier. I'm very comfortable with my sexuality. In fact, I'm pretty proud of it, and I love it when it comes up into discussion. I don't wear it on my sleeve, but I am very proud to be a gay man, and my kids are very proud of me as well.
How old are your kids?
My oldest is a 16-year-old sophomore in high school. My daughter is a freshman, 14-year-old freshman in high school, and then my youngest is a 12-year-old 7th grader at the middle school.
And so the discussion with your wife was difficult, or soon to be wife. What about the discussion with your kids? Did you have the same discussion with all 3? Did you have separate discussions because they were different ages?
Yeah, I came out to my son first, about 2.5 years ago. He started using the term gay a lot, you know, like that's gay, that's, you know, in a very derogatory way. And of course, I don't put up with any name calling whatsoever, whether it be racial or anything else. And he just started like I tell him that, and more often he started saying, you know, why does it bother you that I say that so much? You know, and it was, he was digging for information, and I could tell. And then finally I had a discussion with him in the car, and you know, I basically came out, well, I had come out to my wife as bisexual, which I considered myself because I was still having sex with her, and I wasn't having sex with men, so I guess I was actually straight, I guess, at that point. But I came out as bi, and I told my son that I was wired as a bisexual man, and that, you know, and he seemed to be happy to finally know that, because I think he had a lot of questions, and things didn't quite make sense to him. I was definitely different than the other fathers in town. So I think in a lot of ways he was relieved, and then my daughters absolutely, positively accepted me, you know, from day one when they heard about this. They were sad, you know, about the marriage, but they were very, very happy to, you know, with the fact that I was gay and that I was being myself and being true to myself. In fact, I'm going to tell the story that I don't know if some of you were here for the vote yes on the one, so I'll tell it again. She was given my youngest was given a research paper to write on, and one of her topics, the topic that she ended up choosing was gay marriage, which I was extremely proud, and she couldn't wait to tell me. You could just see it on her face. So that's all good in that department.
And yes, on one turned out very well, I guess. So Jill, why don't you tell us a little bit about what your journey has been like?
Sure. So I grew up in rural Michigan in the Upper Peninsula on the Canadian border. And my experience growing up in a rural community, I think, definitely shaped a lack of understanding. I didn't know any gay or lesbian people. The only gay person that I knew about as a child was a cousin of mine who lived in Arizona and unfortunately died of AIDS in the 80s. And that was sort of my only awareness of a person who was gay. So growing up, I knew there was something different about me. I didn't necessarily have any language for it, and I certainly didn't have any examples for it. Before high school, my family moved to a suburb of Chicago, and I went to a private Christian high school, where I actually would have been kicked out of school for if I had disclosed that I was homosexual or if I had homosexual feelings. So throughout high school, you know, for adolescents really developing attractions to women, I knew that I couldn't act on those attractions. And that was really upsetting to me just in terms of my own development and also in terms of my faith. I'm still a person of faith. I actually attend a Baptist church in Portland. My faith is really important to me. And I was separated from my faith for a really long time because I didn't think that there was room for me within my religious community as a gay person. So I didn't end up coming out until college. I went to the University of Michigan, which is a liberal bubble within the state of Michigan. And there was a huge community there. And there were lots of opportunities for me to get involved in the community there and discover people just like me who had experiences like mine, and it was great. And I was lucky that my older sister was very supportive of me. My parents, it took them some time to accept that I was a lesbian, but they did come around, and actually my mom flew out here from the Midwest for the election night because I was working on the Yes on One campaign. So that was great. You know, my parents, just when I came out, I was very scared of all the horror stories that I had heard about people losing their families and having that separation. And for me, that wasn't my experience. I consider myself to be really lucky and fortunate to have the family and the experience that I've had. And also to choose to live where I've lived. In Portland, I feel very safe and accepted. Because of how I present my gender, I'm very feminine. I come out all day, every day. I don't think there's a day that goes by that I don't come out to someone as gay or lesbian, and so I get that opportunity to challenge stereotypes almost every day, which is sometimes fun and sometimes not fun. And I think that that's, you know, within the medical community, that's where I've struggled the most, is just this idea that there's always assumptions made about me. I've actually never gone to a medical provider where an assumption wasn't made about me. And that's disappointing, and I get it, but I'd like to see that change. I'd like to see the forms change. I'd like to see the conversation change. I'd like there to be more room so that maybe I don't have to correct someone's assumption when I'm coming out. I can just come out.
Could you tell us about how you reconciled your faith? Because whereas I mentioned briefly that there's a medical legacy of distrust because homosexuality was for a long time considered a mental illness, that's resolved for the most part. But the immorality, the connotation of sin, all these faith-based judgments, can you help us understand how you, as a self-identified lesbian, reconcile that so that you can feel whole and not conflicted?
Sure. Yeah, I mean, I think I was asked to leave, you know, the church that I had grown up in when I came out, and I was really separated from a lot of the family friends that I had grown up with when I came out as a lesbian, and so it was really harmful to me that I was being hurt by people in the name of God, and being told that I was a sinner and that I was going to be separated from God, and even that I was going to go to hell. I mean, I think that's a terrible thing to say to someone. Someone said that to me when I was out doing some work on the Yes I Won campaign, and my response was, that's a terrible thing to say to someone. You know, because it just is, but it was said to me a lot, and so I just sort of walled off. I didn't want to deal with that because it was so upsetting and so traumatic for me to have gone through that. That when the first campaign came about for gay marriage in Maine in 2009, I was actively involved in that campaign, and I knew that when that law, the newly passed law, was put out to voters for referendum, that we were about to see a lot of opposition from communities of faith in Maine. And I sort of decided that I had a choice about that. I could live through that and become more angry and more hurt and allow myself to be re-traumatized, essentially, by every ad or every letter to the editor or every news interview that happened where a person of faith said something awful about my community, or I could try to reconcile it. And I actually ended up doing a little church hopping within Portland, and I grew up Baptist, so I found a Baptist church that was led by a woman, and she happens to have a lesbian daughter, and it's an open and affirming faith community. Even if marriage hadn't passed, I could have had a religious wedding ceremony at my church, which is really great. I like to tell people that when I was out campaigning, that I was a Baptist who wanted to have a religious ceremony at my church. So, you know, it was important for me to do that work because I believe I would have been re-traumatized during the campaign if I hadn't found that faith community and done that work to reconcile.
So you've almost shared with us this awakening you've had and how you've dealt with it, how you've sought supports for yourself so that you didn't feel like you were crumbling. I wonder if we can switch the focus a little bit on healthcare. The good interactions you've had and some of the bad ones and how they could have been better. What are some very practical tips we can learn as providers of tomorrow? I think there's a very enthusiastic, I want to talk to you.
It's actually it's a very shy, I don't want to step on anybody's toes, so I haven't been anything. So I mean, I had a lot of, as a trans person, I think that there's like, there's a cacophony of misunderstandings that happen in pretty much every medical visit you're going to experience, whether it's forms or whether it's, you know, physicians, if you're going into, you know, like my friends and I, we used to all go to get screened for our annual, like, or our 6-month screenings at the same time, you know, so that we would all kind of have like a buddy system because doctors would assume we had different bodies, you know, or a group of us didn't get called in once because we were all waiting and we all had to fill out the forms, and so we all had to check female because we were all female-bodied, and we waited for like 2 hours because one of the nurses kept looking through the door and looking at the form and being like, well, they're not there, and like leaving again. It's like, none of us looked female, and we're like, you know, but that leads into this little piece that I was telling Steve on the way down. As part of my, you know, stopping transition, I was put through a number of screenings for different types of cancers, and these were initiated at a place called the Women's Center. And for my first visit, I walked in, and I maybe got like 2 feet in the door, like just the waiting room, and like everybody in like the reception area kind of like poked up and two people came over, like immediately, I had taken my coat off, and they said, come right this way, and took me through the, the waiting room and down a hallway and into a little room that was like all floral and pink and nice, and like gave me this like super feminine Johnny and said, put this on and the doctor will be right there. And I sat there kind of like bewildered, like nowhere did I fill out my name, nowhere did I check in, and I could only imagine that they had been tipped off that there was going to be this trans dude who was coming in, but like, what if some dude walked into the room, like, I was just like, oh, right this way, and like ushered in and put in this pink room with this like super like, Johnny, and was like, changed, like, because that, like, if that was like a very close timing thing, like sometimes dudes go to appointments with their female friends or companions, like, glad it was me. Leaving that appointment, I had an endometrial biopsy that day, and so they were like, you're gonna be uncomfortable and you're gonna bleed, and here's like an absorbent pad, and I'm like, I wear boxers. Like, and like, I was there with my lesbian identified partner at the time, and we had to like switch underwear. So I'm like cramping and miserable and feeling really strange about having some kind of like gender secret, that I'm like experiencing some like postmodern cross-dressing or something, and like, I'm like, this is miserable, and like, I walked out and they had recommended that I get ultrasounds, I dubbed, transvaginal ultrasounds, and so, to monitor my cysts, and so I asked the woman who was scheduling the ultrasounds, I said, where this is kind of an invasive procedure, is the tech trans aware? Like, in Midcoast, Maine, you didn't even ask trans friendly. Like, do you know what I am? Is like the closest you're gonna get to competent care, but, and so she says, let me get you somebody else. And so, I'm glad I asked, and so she calls the dispatch or whatever, and I'm standing across the little thing from her, like cramping and grumpy, and she was like, yes, it's a patient of so-and-so's, it's having an ultrasound, at which point I just like look at her and I'm like, and she goes, it's the transgender. I was like, thanks. You're really helpful. So that was my day at the doctor's office. That was one of them. I have a lot more. Those of you in my small group, I'm happy to answer questions.
I've had experiences that are on both sides of the spectrum. I've had some really great experiences with medical professionals and some really pretty terrible ones as well. Start with the bad ones and work with the good ones. But when I was in college and I first started identifying as male, I wasn't on hormones yet. I hadn't legally changed my name yet. I was living in an all-girls dorm and suffering from some pretty severe depression and anxiety, and had a really bad night. My roommates took me to the ER because I wasn't feeling very safe. And then whoever was working at the ER was the least trans-friendly person I've ever met in my life, I think. So here I was at like a really low place, feeling like I might hurt myself. Luckily, I had some really amazing friends with me. They like left me in the hallway on a gurney next to somebody who was wasted and tied down and screaming, and left me there for like an hour or two. And then the doctor came in and started going over my form and kept calling me she and by my given name at birth, and I kept saying like I go by Steven, like I use male pronouns, and he was like, and so then when he finally got what I was talking about, he was like, oh yeah, no, you're not transgender, like this is just something that like you go through, and like this is probably why you're depressed, and I can't believe that like your friends are like give me a break, like this is your problem. And then like I had a friend who she came in and pretty much laid the smack down and got me up and out of there. And luckily I had really great support system of friends who watched me that night and made sure I was okay, and made sure I went to somebody who, you know, like went to a counselor who I could talk to, because it could have turned out very differently, having gone to the ER for feeling, you know, like you're gonna injure yourself, and then being told that who you are is wrong, what you feel is wrong, your friends are like pandering to this crazy idea that you have in your head, and that they're like, you know, the best thing that you could do is like start calling me by female pronouns and ignoring that I'm having these feelings. Like, it was like really bizarre, and so that was a negative experience, to say the least. I also, when I started transitioning, the doctor that I worked with is a family, worked in a family practice, and he had worked with male to female transsexuals before, but had never worked with a female to male transsexual before. And he was very honest with me in that he was open. At the time, there wasn't a lot of doctors who would prescribe cross-sex hormones. There was like probably a group of like 5 other guys. We were like all going around the different family practice, like who's gonna take on. And a lot of people were like, well, I'll take on one of you, but I don't want like trans people like overrunning. Like, as though there would be herds of like transsexuals. And then like, you know, like, and what would that mean for their family practice, and how are we gonna talk, like what are we gonna do when you're sitting in the waiting room, like, and everyone's gonna know there's like a transsexual in here, and like, what does that say about us and our practice? Like, I felt very lucky that my doctor, even though he had no experience helping someone transition from female to male, he called a doctor that he knew in Canada who had done this before. He educated himself, he read articles that I sent him. Like, we talked about like what transition meant for me, which I think is really important, not to assume that like because someone comes in and says like, this is how I identify, like that means, oh, like I think May was speaking to, like, that means we have to put you on hormones, and in a year you're gonna have, you know, top surgery, and like in 2 years you'll have hysterectomy, and maybe you'll have bottom surgery, and like, and you date this kind of person, and this is like, there's all different ways of being, it's all very mixed up. So that he was willing to listen to what I wanted and what I needed, and work with, and make sure that like, I also didn't want to have gender, it used to be called gender identity disorder. It might be still in the DSM, but under a different name now.
So it's gonna, in the spring, when DSM-5 comes out, it'll be gender dysphoria.
Yeah. At the time, it was still gender identity disorder, and having that on your records meant that you might not be able to get, during the times that I've had healthcare, like if I have that marker on my chart, like I'm probably not going to get anything paid for, because health insurance, at least 10 years ago, was not at all paying for hormones or surgery or even routine blood. So I happen to have high cholesterol, and so every time I went to the doctors to get blood work done, testosterone injections are processed through your liver, so I have to get my liver levels taken to make sure that I'm healthy and safe. And so every time he would run blood tests, he would just say, oh, like, you're checking your high cholesterol. But I feel very lucky that I had a doctor who is knowledgeable and willing to work with me. I've had, like I said, I can talk more in small group settings about other experiences.
It sounds like self-advocacy has been a very important component.
You know, it's one of those things that, like, it's great, that I think it's wonderful that UNE does this, because I think the less GLBTQ, etc. folks have to advocate for their own, like, it's really nice, like, I had to go to the ER recently for something, and they were running some tests, and they were like, is there anything else we should know? And I was like, well, you should probably know that I'm trans. And they're like, okay, what does that mean for you? And I gave a quick explanation, and they're like, okay, we just have to ask, like, do you still have your female reproductive, or like, pardon the term, but like, we need to know these medical things. And in 5 minutes it was over, and nobody batted an eyelash, and nobody switched pronouns. It was very like, okay, like, I didn't have to go into this hour-long explanation of like my coming out story, like, which I'm more than happy to do here. You don't necessarily want to have to do it in my doctor's office, but if it means making that experience safer for the next person, like, I'm happy to do it. It's just nice when you don't have to do it.
Brian, is self-advocacy as much of an issue for you? Do you have to correct misconceptions? Because I would imagine if you said, oh yeah, I'm the father of 3, there are certain assumptions made about that.
Right. I'm actually feel very fortunate. I still have the same doctor that I had for years, and I transitioned with him, and he was very sensitive about it. You know, I really commend him on the way he approached it. I guess the one thing that I sort of had difficulties with was at the time when I did come out to my doctor, he suggested that I get a full STD workup, and I knew it was going to be fine, but I also wanted it because I was going to enter into a relationship with another man, and we're going to show each other's dog. I was doing everything the way I was supposed to do, and then when it occurred to me that that was now going to be on my record, and I have a lot of clients who are doctors, and in this particular medical group, and it just made me feel very uneasy that this could be shared. I mean, God knows I was the topic of cocktail parties in Kennebunk. I just didn't want to add to that, So that was the only bad experience with my medical. And I'm very happy now. Everything's out in the open.
You say you come all the time, so like in healthcare too?
So I think for me, I never had the choice not to self-advocate for good medical care. Having a sister was a doctor and a brother-in-law was a doctor. If I didn't take care of myself, they were going to come after me and make me take care of myself. So, and I have a lot of privilege. My parents had health insurance through their jobs, and so I've just always been insured. I'm one of the few people that I know actually in my world who's always been insured. But for other folks in our community, this ability to self-advocate is rare, I would say, because of sort of this historical shared history of trauma, and when that trauma gets triggered, when those buttons get pushed, a lot of people shut right down and they lose the ability to advocate for themselves, and maybe there's someone else, like Stephen shared, who advocates for them, but maybe there's not. And so I just think it's so important for me when maybe those buttons got pushed, I was able to sort of just take a deep breath and move forward and advocate for what I needed, but not everyone's like that. And what does that mean about the care that they are or are not getting? And some examples of that, I think, are, yes, the assumption that I'm straight. I've had to, disclose that I'm a lesbian in every single time I go in for an annual exam. And then when I do disclose that I'm a lesbian, there's a lot of assumptions that are made about what my medical needs are or aren't. So either, oh, well then you're not on birth control and we don't need to talk about that. Which, maybe I would like to be on some sort of birth control regimen for other reasons. Maybe my periods are really difficult, or maybe I've been having some problems, and maybe I would like to talk about those options. The other assumption that has been made throughout my life is that I'm not at risk for STDs. Because I'm a lesbian who has sex with other women. So that's an assumption right there, because not everyone who maybe identifies as a lesbian or gay or queer or trans, that doesn't necessarily dictate what our behavior looks like. So right there, if someone's making the assumption that I'm not at risk and that I'm only having sex with women, if I were maybe feeling like there was a risk factor and I did want to be tested for STDs, I would have to then bring that up to this person who's basically made an assumption about what my needs are and what my sex life looks like. And that's uncomfortable. And I think the other big assumption that's been made is that I used to work in the domestic violence field here in Maine, so I do a lot of education with health providers around screening for domestic violence. And so often when I've needed to go to the emergency room or just with a primary care provider, if my partner comes with me, they never separate us. They never ask to speak to me alone. They sort of assume that there's probably not violence in my relationship. And luckily for me, the majority of the time that has been true in my life. I've been in relationships with people who treated me really well. But that sort of assumption that there's no domestic violence, no STDs, and no need for birth control or any sort of reproductive health care within a lesbian relationship is really problematic. And that's just something that I would like to see change. I'd like to not have to, because every time I've had to go over those barriers to get the health care that I need, I think about the person that might just shut down and not go through it and not get the health care that they need, and that's really unfortunate.
What's interesting about assumptions is that when it comes to gay men, the assumption is you must absolutely screen for STDs because all they do is have sex. Whereas it's the opposite. Like there's a gender bias regardless of sexual orientation. So we have about 10 minutes. Can we open up the questions from us? Yes. Any burning question that you would like? Yes.
so this is for Stephen and Maya. When you guys go to, let's say, a family practice doctor, or whenever you go to see a new physician, and some places do it differently. Sometimes you meet with a nurse, sometimes you meet with a doctor, or sometimes you just get shuffled right into that room and then think Johnny. Have you ever had an experience where the doctor was unaware of what your genitalia looked like, and you had to what does that experience look like? Is there a place on the form that, I know for a fact that there are not places on the form, whether or not you have a cervical vagina, but how would you recommend that we address that issue, maybe on intake forms or with taking history and stuff?
I think proper utilization of the terms sex versus gender will answer that question if you want an intake form in 5 seconds. What is your biological sex? What is your gender? Both questions on the form. Because that way you're showing that you recognize the difference between the two. So I'm presenting masculinely. My biological sex at birth is female. So now you know what my body looks like and you know more about me. I have seen on forms, I caught a glimpse of my form that the physician had during a screening where they, mark any areas of abnormality. And I'm not sure how much you all are familiar with physiological changes through cross-sex hormone use, but in female bodies taking testosterone, that mimics male puberty. So we all differentiate into one sex or another, but we have capacity to a certain point with cross-sex hormone therapy to bring on secondary sex characteristics. And so for female body people, that means that their clitoris, which is the equivalent of 2/3 of the penis, is going to respond to male puberty, respond to puberty in the same way. And so my form had this big circle around something's weird here, and then I had, so that was exciting. I felt really special. And then my one doctor I saw was my family practitioner, for my pediatrician. And I went back to her when I was living in the Mid-Coast because I was like, you're the only person I know, me, so you're not going to make me be such a jerk. So I went in and she was doing just an annual exam, and she remarked so excitedly, supportively, with her fascination, she's like, wow, it really does look like a penis. And I was areas on forms where you can indicate your biological sex and your gender help to maybe offset some of that curiosity or surprise, so that physicians can be more prepared to work with trans bodies. And also, that's a thing that would be answered by a very pretty basic education about how bodies change in cross-sex therapy.
One thing, I've had the same experience at a certain clinic in Portland at least 2 or 3 times now, and we're actually going to be doing a trans sensitivity training because of this, which is great. But where if you have the intake form, which leaves room for your gender of male, female, transgender, other, that you have to make sure that the doctors are then educated as well. It's not just in the reception, and that information is passed down, because I've been in the experience of having been okay, great, there's this check mark, I wrote down that I'm transgender, I added a little asterisk, female to male, this is what it means, started going into the exam, was in the middle of the exam, and I heard, oh, you're a transgender. Yep. Oh, I need a whole different kit. Can you just stay here? And I'm like, okay, I don't have my pants on, and this is not, I assumed this was a safe place. This now feels very awkward and uncomfortable. Now that you're fumbling around, you don't feel I'm sure she apologized profusely. I'm sure it was just as embarrassing and awkward and uncomfortable for her, which all could have been solved by somebody just making sure on my chart that information from the reception area to the exam room, because it's a whole nother level when you think you're safe and then you don't feel safe and then you just feel humiliated. So I would say if you're going to align yourself as an ally by having those forums, and you have to make sure that like everybody in the practice is on board and everybody knows what that means and that information is getting passed on.
It's not just about a piece of paper, it's about education and sensitivity training. Was that a question?
Oh, yeah, we've been doing standardized patients. And every time I do a standardized patient, or I speak to a standardized patient, I try to ask the standardized patient, do you identify as male, female, or both? I tried to ask, do you have sex with men, women, or both? And that question got a little botched. But I tried. And the problem is that many people in this community, as I'm sure you know, are offended by that question if they are not lesbian, gay, an ally in some way. So they look at me and say, why are you asking me that? Do I not look female? What are you saying? Do I look like a man? And so I'm questioning how to, I don't know if this, who to ask, how to address this best so that I don't offend anybody.
Yeah, I just wanted to say really quickly that my work in the domestic violence field is that people are sometimes offended when you ask the question, are you safe in your relationship? Are you safe at home? And yet I still encourage every medical provider to ask that question. And I would say the same about this. You know, I think what you're trying to do is really great. And the one time that a patient breathes a sigh of relief and then feels safe talking to you as a provider will make it all worth it, right? So, you know, maybe you can preface the question with, we ask all of our patients this, or, you know, this is the conversation I have with everyone, so that no one feels singled out. But there's so much homophobia and you know, gender fear in our culture that, you know, unfortunately you're probably going to keep having those experiences. But thank you for doing it anyway.
And I could also tell you the first thing when you have difficult emotions to manage from your patients, the first thing to do is to acknowledge the emotion. And then if you ask that question and someone seems offended, the first thing you should say is, I'm sorry if it seems like I've offended you. I'm only trying to make sure I don't make any false assumptions. Is it okay if we continue? So I can get the right information so I can give you the best care. So the only thing to add is that always acknowledge your patient's emotion, because if you don't, it'll just like follow you with this like a little black cloud, and it'll create problems for you if you don't do that. But don't stop asking those questions. One more question, yes.
So you had mentioned that you went back to your pediatrician because you knew him. If someone were to be a doctor for someone in that transition age, do you think it's important to either on a form or just every time ask them how they're progressing in terms of, you know, their gender identity, because that might change around that age. So how would you suggest addressing that to make sure that as a doctor we can kind of talk that out earlier and get a plan for them earlier?
Just to clarify, this is a patient that you would be working with on a regular basis. At that point, I think that's something that moves into the realm of like conversation between you and the patient, and wouldn't have to be documented on a form. It would be documented later in your notes for that patient, just as, you know, anything else you would talk about would be. And I think this is kind of where you start to see the crossover between, like, at least when I was transitioning and before transitioning, like I had to see a therapist in tandem with my medical practitioner, because there's a document called the Harry Benjamin Standards of Care, and that document outlines, and it's a very difficult document, it's very restrictive, parts of it are potentially dangerous for transgender people, including require, and I think they've started to become more relaxed about this, but it used to require you to live for an entire year in your target gender before you had access to transition. Which, you know, if you're a 40-year-old biological man and you are trying to gain access to transition, that is a very, very, very dangerous thing to ask somebody to do. But so this is where you would see that kind of overlap, where if you are working with a young transgender person, there's going to be a requirement that they're also working with a therapist, and so there's going to be some interplay there, where some of that is your job and some of that is their job. But just like with anything else, you know, like how are you feeling? You know, like if you've started them on a hormone regimen, or, you know, for younger people, they have blocking drugs that can delay puberty so the children don't have to choose so early, which is amazing. But, you know, how are you feeling in your body? Have you noticed any changes? How do you feel about those? You know, and at that point, it would just be like working with any other medication. You know, like, have you been feeling more anxious? You know, oh, maybe we can drop your dose. You know, I mean, you would ask that about many kinds of medications. And so it's kind of at the level of, is this working for you, and how do we make it work for you? And part of that, where you're working with a person's body first, and then their feelings second, and then the therapist works with their feelings first and their body second, and you kind of dance.
We are actually running out of time, and if you had more questions you wanted to ask, then that means that our panel has done a very, very good job at making you curious and wanting to know more. So there's two things that's going to happen. We'll get to explore these, and maybe you'll have the good fortune of being with one of our panelists in your small room. And I will stay with half of you and explore the medical consequences of what we've learned about. But before we move ahead, please join me in thanking our panelists. Brian, Stephen, Maya, and Jill, thank you very, very much for spending your afternoon with us and sharing the good and the bad of your personal journeys with us. If you are not being able to speak for 14, then you should here's what we're going to do next. So, in the spirit of It's All About the Patient, we have a very, very rich narrative from 4 very, very diverse patients from the community, or people from the community, who one day may be your patients. Hopefully their stories will tell. What I want to do is over the next 45 minutes, take you on a whirlwind tour of the health inequities that exist today in patients who identify as lesbian, gay, bisexual, or trans. There are 5 things I want to accomplish. I want to revisit the developmental challenges with you because they are at the core and they generate all of the health inequities that we see further down in adult development. We're going to look at adults, gay men, lesbians, and just talk about the barriers to healthcare. Your task is to make sure that we can overcome some of these barriers in years to come. All right, let's talk about young people. There are 3 domains: the developmental challenges, the issue of violence and bullying, and then suicide. When you are, even I'm going to fall asleep. When you're, thank you. When you are growing up and feeling different, you may or may not have the language to say so. It's very conflicting because you may see enemies more so than allies in your surroundings. This is reinforced not just in faith-based organizations, which we heard a little bit about through one of our panelists, but there's also within the medical community individuals who use the authority that comes with their title or their training to spread their beliefs that are not necessarily evidence-based or scientific. For example, if you were to go into pediatrics, and I ask some of you who were here during the lunch hour, would you abide or make clinical decisions based on position statements of the American College of Pediatricians or the American Academy of Pediatrics? If you pick the American College of Pediatricians because it sounds authoritative, you've actually picked a group of pediatricians within the Academy, which is the official governing body, that has decided that we should not support young people who struggle with same-sex arousal or attraction, but rather we should send them for conversion therapy. Now, the American College of Pediatricians has sent pamphlets to school superintendents across the country. Those superintendents have then gone on and distributed them to parents. Now, if you are a parent of a child and you've seen literature from the American College of Pediatricians, you would suspect that that's what doctors think, or that's what doctors recommend. They are a minority, but they are still a very vocal minority. What you're most likely to hear about are religious movements such as Exodus.
Now, just a word of caution. If you are a person of faith, and if your faith is very important and decides, helps you make decisions every day, I'm not picking on you and I'm not telling you not to be religious. I am suggesting that you do not allow your faith to create hurdles or barriers for healthcare. And I'm using extreme examples, obviously, so I don't want you to generalize to all people of faith. So Exodus is a faith-based organization that publishes ads such as this that promotes conversion therapy. Conversion therapy is a form of treatment that ungays people, that helps people get rid of same-sex longing and attraction using very, very simple operant conditioning. So you reward non-same-sex arousal, you punish same-sex arousal, and you use faith-based reinforcements such as a promise of eternity with God as opposed to damnation in hell, such as we just heard from our guest before. And the thing is, it's very, very, very clever marketing, because if you're 15 and you're struggling and you see this, and you know, like, wait, I can be this person. I questioned homosexuality, and when I discovered a way out of it, I took it. Well, that sounds like a very, very soothing alternative to despair and dismay for some people who struggle with coming out. It is challenging because many rites of passage are denied. You can't take your girlfriend, boyfriend of the same sex to the prom. The school may actually shut down the prom if you want to do that. You've all heard about these stories in the news. There are not very many role models. Now the thing is, just because Modern Family is very popular, think about it, Adam Romney thought that was the best show on TV. We know what her views on homosexuality are. It's very easy to distance ourselves from fictional characters on TV. That doesn't make them real. The fact that there are gay characters on TV is one step forward, but it doesn't mean that we've crossed these barriers completely. There's a lot of perceived adversity within government, within political parties, within the medical establishment, and that's because of the legacy of homosexuality as a mental illness. The most interesting thing, and if you remember just one thing today, this is what I want you to remember. When you are 15 and you're struggling with same-sex arousal, there's also something very unique about you because of all this perceived adversity. There's a very, very elegant study that was done. They asked adolescents this very simple question. Tell me about yourself in the future. That's it. Just write a one-page essay and answer this question. And then they did a qualitative assessment of what they saw. So when they looked at what the kids wrote, everybody talked about achievements and jobs. However, none of the lesbian and gay kids talked about relationships, parenting, marriage, midlife events. And if we quantify their life events, we got a mean age of 35 for the lesbian and gay kids, and we got a mean age of 51 for the straight kids. The relevance to you as healthcare providers is that that person who can only project themselves in the future to an age of 35 is going to make different decisions in the moment than someone who can project themselves to 51. That person who can only project 20 years in the future is more likely to take risks, more likely to not invest in the future because the future isn't as long as it appears. And that's been correlated with HIV risk behaviors, substance abuse, so on and so forth. And the fascinating thing is that these risk factors, they carry on into adulthood when we've studied gay men and lesbian men. Of the issue of bullying and physical violence, there's some very humbling and actually scary data that comes out of Chicago, where they published 25, and I don't know what a half anti-gay slur is, but so a little bit over 25 anti-gay slurs every day. If you grew up in that environment, it's very oppressive, and certainly not good for your self-esteem. That's how this whole thing comes together and creates a very, very overwhelming amount of adversity. Being chased or followed, being kicked, punched, or beaten. All of these things are common practice for many LGBT kids. Maybe these things are changing. Maybe if we had literature from 2012 to present, it would be hopefully better. But these people that were in those studies are the adults of today that we will be taken care of. And it shapes their psyche. It shapes how they experience the world, their level of trust or distrust. When you are stigmatized, You don't necessarily have anybody to look up to as a role model. You take more chances. You're less likely to do well academically, so on and so forth. This is, if you're interested, Caitlin Ryan is a pediatrician, and she's been more of an academic leader in this field. You should look her up, and she has these very interesting diagrams, such as this one, that puts it all together, and what leads to internalized homophobia is kind of a cumulative effect of all of these stressors. Ultimately, the worst outcome in perceived adversity is suicide or suicide attempt. Despite the fact that it's not mentioned all that frequently in public service announcements, LGBT youth have a 3 to 6 times greater likelihood of attempting suicide than their straight peers. The loneliness, the inability to feel that you can reach out to someone, all of these things who tend to create this cosmic cruelty, and it's a heightened risk factor. Loneliness and social isolation are the greatest risk factors. If we look specifically for which patients are more likely, young men who are effeminate, who use substances, who have just come out of the closet are at greatest risk for suicide attempt. And as you may know or will learn when you do your behavioral health module, men are more likely to complete a suicide attempt. Women are more likely to attempt suicide. Now, to not be all grim and to be a Debbie Downer, there are mitigating factors to suicide. So some epidemiologists out of Columbia have actually looked at, well, what are the buffers that we can help and reinforce to try and present an antidote to suicide attempts? Well, if you live in a community that has a greater proportion of same-sex couples, registered Democrats, maybe it's a statistical artifact, I'm not sure, I'm not trying to start a fight. If there's a gay-straight alliance in school, if there's a non-discrimination policy in school, and an anti-bullying in school, the more of these buffers you have, the more protected you are from attempting suicide or having a self-harm behavior. Now, it's kind of nice to talk about this in Maine because this latest election results are also going to be a buffer for Maine's youth who are struggling with their sexual orientation. Most LGBT youth successfully navigate these challenges and grow up to be adults. As adults, there are 5 health domains that still present a greater risk for health inequities. Substance abuse, which you recognize was a risk factor during youth. Domestic violence, which we heard about, and I swear I did not plan this, I'd never met her before, but she talked about domestic violence, our panelist, Jill. Hate crimes, barriers to healthcare, and institutional discrimination, which is probably the most fascinating. So substance abuse. Gay men and lesbian women drink more and use more tobacco. That is a fact. It used to be thought for the longest time that maybe it was because the way to break social isolation was to meet at bars. So where am I going to meet other gay men? I'm going to go to a bar. Or am I going to meet other lesbians? I'll go to a lesbian bar. What do you do in a bar? Well, you drink and you smoke. Well, that is changing because in many places across the country, and I will admit I don't know what it's like in Maine, but in many places, such as Philadelphia, you can't smoke in bars anymore. You have to go outside on the sidewalk. But you can still drink, though. And drinking, the disinhibiting effect of alcohol is not going away, and is also very often a means to an end for people to try and embrace social isolation. While I expect that tobacco use may not be as much anymore, I don't suspect that there's going to be any decrease in alcohol dependence rates in gay men and lesbian women because of the social facilitation that occurs with alcohol. It's a form of self-treatment, if you will. There was some talk many years ago that tobacco companies would specifically target LGBT youth to try and recruit them as customers for the long haul. From a mental health perspective, it is very well known that there is a higher rate of mental health utilization, but it does not mean that there is a higher rate of major depressive disorder or other psychiatric illnesses in the gay and lesbian population. The fact that you seek counseling and are given a diagnosis of adjustment disorder, for example, does not mean that you are mentally ill. It means that you suffer from symptoms and are reaching out for help. It's very, very different than major depressive disorder. And we've heard from our panelists that depressive episodes have been a significant trigger in their journey of self-acceptance. Institutional discrimination is an interesting societal contributor to distress, which I'll get to in a second. Domestic violence, Jill talked about. There's this unfortunate assumption that lesbians do not get into fights with each other. There's an unfortunate assumption that gay men are always happy and never get angry at each other. Screening for domestic violence is actually seldom done because of a false assumption in an emergency room setting. They'll ask everybody, but they'll just check off the box without asking when it comes to men who are partnered with other men or women who are partnered with other women. Physical violence and hate crimes are not recognized everywhere. There's a risk in the workplace, and no setting is in that setting. Barriers to health care is something that is becoming less and less of an issue. Most institutions of higher learning do offer same-sex benefits, so if you are a faculty member here, I'm suspecting, and maybe Dr. G or Dr. Day can tell me, you can offer domestic benefits to your same-sex partner. That is the issue at the University of Pennsylvania. Last year, the University of Pennsylvania offered gender reassignment surgery as part of the health plan coverage, but that was just last year. They had offered it under the student health plan the year before. These things are changing ever so slowly. There's still a lot of work to be done, but the trend is very, very positive. Oh, and one thing about the presidential memorandum, this is not that long ago. The issue was, it was a hospital in Miami, 2 lesbians were vacationing. One of the lesbians ended up having a hemorrhagic stroke. When she was brought to the emergency room by her partner and their children, the surviving partner and the children were denied visitation rights. They were told by the staff, well, you're not really family. And unfortunately, the patient expired without being able to say goodbye or without her family being able to accompany her during her last breaths. That created a lot of outrage, and President Obama signed the presidential memorandum, and that's what the JCO, the accrediting body, now says. If you do not offer same-sex visitation rights, you will not be eligible for Medicare and Medicaid reimbursements. There's distrust within the doctor-patient relationship, and one of your classmates shared, I'm afraid to say sometimes, like, do you have sex with men, women, or both, because people may get upset with me, and that is absolutely true. But there are other questions that you will ask your patient that will also make them upset, or that you will overreact, but that doesn't give you license to not ask those questions. You will never be faulted for asking a question that allows you to make the right diagnosis or the right treatment. As long as your question is based in fact and has a diagnostic motivation, then it's okay. Your patients are allowed to get upset with you, they will. No one's immune to it. But you just have to acknowledge their emotion and move on. Not asking the question does more harm than having to be at the receiving end of someone's frustration, if only for a brief moment. Institutional discrimination is the adult version of perceived adversity when you're 15 years old. So the 15-year-old that gets bullied in school perceives enemies everywhere and receives negative messages. When you're an adult and you have a job and live by a home and a family, while you're not worried about being bullied, things like this actually make a difference for you. When a state passes a law that says that same-sex marriage is going to be banned or prohibited, or when a state decides that there will be a proposition put to a vote where the Constitution will be changed, it creates a high level of distress in LGBT respondents. Looking at epidemiological data, you see here that in states who from 2001 to 2005, those states who instituted bans on same-sex marriage saw a 36% increase in mood disorders, 42% increase in alcohol use disorders, and a whopping 248% increase in generalized anxiety disorder. But you may be thinking, wait, that's not the whole picture. What about those states, people who didn't identify as gay or lesbian? Maybe they thought it was stressful as well, or maybe just all of Americans who are gay got more stressed in those 4 years. When you compare all of those things, the fact remains that if you were gay or lesbian and lived in one of those states, your overall mental health index actually suffered. Let's focus now on lesbians and then men for health inequities that are more specific to those segments of the population. 4 health domains for lesbians: breast, cervical, ovarian cancer, and sexually transmitted diseases. Lesbians have an increased risk of breast cancer. They don't have any special kind of breast cancer, they just have more of it. Biologically, they may be at greater risk because they're less likely to become pregnant. They may be at greater risk because of use or non-use of oral contraceptives. But the fact remains, regardless of the risk factors, is that when lesbians are diagnosed with breast cancer, it is almost certainly at a much, much more advanced stage of disease than in their heterosexual counterparts. They don't have any different kinds of cancers that are more aggressive, they just don't go to the doctors as much or get screened as much, either because assumptions are made about them or because the lesbians themselves don't seek health care. Last year I gave a similar panel at my own institution, and one of the panelists was a lesbian who just that morning had learned that her partner had been diagnosed with stage 3 breast cancer. If you're not familiar with staging, there's only a stage 4 beyond that. Fortunately, a year later she is fine, but then she ran into the issue of her partner not being covered under her health care benefits. You see how all these things tie in together. It's very simple. I break it out into very simple modules, but it's always a domino effect of all these things coming together. We think that maybe the increased use of alcohol may be a risk factor for lesbians developing breast cancer, but the thing you need to remember is that diagnosis is always going to be at a more advanced stage. Cervical cancer and ovarian cancer are also detected in greater rates and always at more advanced stages in lesbians. GYN care in lesbians is never, never optimal. There are assumptions made about lesbians that result in not getting pap smears. Getting a cervical cytology is just as important in lesbians as it is in heterosexual women. Unfortunately, some physicians will assume that lesbians don't have sex with men. That's a false assumption they may have had in the past. And even if they've not had sex with men, they are still potentially exposed to the human papillomavirus, which is the leading cause of cervical dysplasia. If lesbians were offered the same rate of cytology, cervical cytology, then the rates and the stage of disease would be equivalent to their heterosexual counterparts. These are the kinds of very simple things that we can change for tomorrow's patients. Now, some of you may be thinking, yeah, but what about the vaccine? But I have no idea what's going to happen to the data, but it's going to be a while before we see any changes from the HPV vaccine. Sexually transmitted diseases, we had like a very honest testimonial from one of our panelists. Don't forget to screen, don't make assumptions that lesbians should not be screened for sexually transmitted diseases. And conversely, don't make assumptions that you should always screen gay men for sexually transmitted diseases. Ask about behaviors before you make those decisions. Let's focus our attention on gay men's health. 3 domains I want to go over with you: anal cancer, eating disorders, and sexually transmitted diseases. Just a methodological issue before we proceed. I'm going to use gay men when I talk about these health inequity findings today. If you are curious and start querying the literature, what you're going to see now is the expression MSM, or men who have sex with men. This reinforces how you should make decisions based on behaviors and not on identity. So if you have a study with men who have sex with men, you're going to have a bigger cohort than if you have a study just with gay men, because there is a component of the population of men who have sex with men who don't necessarily identify as gay but present the same risk factors. So those are truer findings that are more generalizable. Okay. Anal cancer is found in higher rates in gay men, and we can say now with recent studies also in men who have sex with men. It is exactly the same pathophysiology as we know to exist in cervical cancer. It has to do with HPV exposure. When human papillomavirus latches onto the anal mucosa, it creates dysplasia, which creates a risk for malignancy in a fashion very parallel but similar to what we know to happen in women's cervixes. It's not related to HIV at all. There are now trials that have shown efficacy in using the HPV vaccine in men who have sex with men. It's a little too early to look at long-term outcomes, but so far the results are very, very similar. There are institutions, the Children's Hospital in Philadelphia being one of them, where they will do butt screens, which is essentially a pap smear, where you get a mucosal cytology only in at-risk youth who do report anal sex, whether it's protected or not, there's still a risk of exposure to HPV, and they follow the same treatment algorithm as they would for cervical dysplasia. Eating disorders are found in greater rates in gay men, and probably has to do with body image and societal pressures to either buff up or be more slender. Bulimia is more frequent in a cohort that comes out of the Massachusetts General Hospital. There's a lot that's been written about reverse anorexia in the gym, in that you don't want to be thin. When you go to the gym compulsively, you actually want to buff up and you're never big enough or muscular enough. It leads to a lot of natural supplementation that may or may not be safe. Creatine supplements have been shown to be harmful to the kidney when taken in very high doses, and there is anecdotal evidence from a limited cohort from the Mazzoli Clinic in Philadelphia that there's a higher incidence of these findings in gay men. Sexually transmitted diseases is unfortunately the first thing we think of when we think of gay men. The numbers do support our concern because there is a higher rate of sexually transmitted diseases in youth, specifically in LGBT youth. It's important to get a good sexual history because the treatment recommendations are different by the CDC when it comes to the treatment of sexually transmitted diseases. The mean of acquisition or exposure to different pathogens will lead to different treatment recommendations based on whether this was heterosexual transmission or homosexual transmission. The thing is, because it's a big issue, the gay community has taken it upon itself to educate its own. And so they have a campaign that actually came out of Seattle called the Healthy Penis. It was very, very successful in Seattle, so the people in San Francisco and their health department turned it into something bigger, no pun intended. So Healthy Penis was just about general sexual health, but then it turned in really about syphilis. Syphilis is on the rise, and that's simply because syphilis and HIV tend to travel together. So the Healthy Penis campaign, and this is kind of the levity part of today's lecture, so they started having these cartoons in some of the publications in San Francisco. So you see the Healthy Penis going to the gym to pump up, and then what he doesn't know is that there's a little bit of a syphilis rash that's following him around. So then he goes to the Gap and buys a pair of jeans, and then like there's Dr. Penis. Someone pointed out that the black penis is taller than the white penis, and I just said, yeah, but the white penis is sitting down. That's to promote stereotypes. Then it became to see like they're kind of the same height. So then the campaign was so successful, they had to come up with part 2. So when the syphilis test comes up, so you see how like the little syphilis looks very nervous and increasingly more nervous. And this is antibiotic who uses a Gucci purse to whack out syphilis. The thing is, well, I think it's brilliant personally, but it got people talking about it. So if you use that to get people more sensitized about their sexual health, that's great. And no matter how many stereotypes are in there, if you get people to talk about it amongst themselves, they're more likely to get tested, and the disease is less likely to be propagated. Now, and then the campaign continues, and this is the syphilis sore, the syphilis rash, so on and so forth. I don't know if I put the, oh yeah, so then there's mascots. Like, have you ever seen a penis this size, seriously? So this was for like some street fair in San Francisco. I forget if I put this here. Yeah. So the campaign has continued to expand, so now you have a Hispanic penis, a black penis, a white penis. They are all the same size. And it has just taken on the kids at the Children's Hospital, the young adults at the Children's Hospital. Actually, we run out of these pamphlets all the time because they just like them, and they will cut out the mascots and so on and so forth. So going back to sexually transmitted diseases, obviously the focus is on syphilis, but we should never forget about HIV. The pandemic is far from over, and whereas worldwide the rates of infection there's now been a plateau, we're not out of the woods yet because there are segments of the population that continue to become infected every day, and that would be young adults and women. The rates of infection in these two segments of the population continue to increase, and within young people, it's not just young people at large, it's social minority youth. So it's Black and Hispanic youth in impoverished neighborhoods. They are the ones who are more likely to be exposed to the virus. And remember, you should link this back to
high-risk-taking behavior because of the inability to protect yourself in the future from that high school study. Related to HIV, there are some cancers that are at increased rates in this patient population. And lastly, a few words on transgendered health, and I want to tell you I cannot do justice to transgendered health topics in like 10 minutes. There should be like day-long trainings, but I just want to whet your appetite, if anything, and I want to make you curious about these things. We've heard two stories, two very different stories from Leah and Stephen. However, in public health clinics in Philadelphia, and I can only speak from my experience anecdotally, most individuals do not transition as successfully. You need to be aware of that, and you can be an agent for change. You can be that person one day who says, you know, it doesn't have to be that way. You can have a healthy, productive life. You can go back to school, so on and so forth. You can be that one person who will take the time to listen and veer that person off of a very, very bad path. So substance abuse rates are higher, victimization rates are higher. There is an association population-wide, and I don't want you to project that onto our panelists, of prostitution as a means to earn quick money, to be able to pay for street hormones. If you don't have benefits, if you don't know where you can go safely to get hormones, and I gather from being here a few times that Portland is a good place if you want to have hormone replacement therapy. It's not like that everywhere. So you buy street hormones, you end up buying reused needles, and you end up with Hep C, maybe HIV. It's a social issue as much as it is a medical issue. The more aware you are of this, you can make a very meaningful intervention in an emergency room one day. Don't forget about the biological body. That's why Leah said, you know, there should be two questions: what is your sex and what is your gender? Because even though Stephen lives his life as a man, Stephen biologically has female reproductive organs. So the screening for cervical cancer is no different than if Stephen were still living his life as a woman. And screening for breast cancer is the same, simply because the breast tissue that remains, if there has been breast ablation, still is at high risk for the development of breast cancer. Male to female transgendered individuals will, despite gender reassignment surgery, still have a prostate, so you need to do prostate health exams as well, as determined by well-being visits. This is just a very brief overview of some of the hormones that are used. So people will refer to estrogen. We heard Maya talk about his dislike of estrogen. Spironolactone is referred to as Spiro. The advantage of spironolactone is because it does have hormonal impacts as well. So that's why we use this instead of hormones, because even though it's a diuretic, we can use it in lower doses because of its anti-hormonal effects. Progesterone and testosterone are used. The masculinizing effects of testosterone are reversible. So once you start testosterone, you have to continue. And if you stop, the secondary characteristics go away. The take-home message today is that it's not just about memorizing the list of health inequities, it's remembering that this is all something that comes together. There are the psychological issues of this person's development, there are the psychosocial issues of the person's social environment, and then there are the medical and biological issues. And as a healthcare provider, it's your responsibility to make sure that you incorporate all three. A few words on how to inquire about these things. Always use open-ended questions. You heard about, do you have sex with men, women, or both? You can also ask, who do you have, are you sexually active? Who do you have sex with? The open-endedness of the question is maybe, by some people, less intrusive as giving people three choices, to make a choice between three things. Always remember that if you rely on assumptions, you will make mistakes, and it is essentially hazardous to your patient's health. Don't assume sexual practices based on sexual orientation. Don't assume sexual orientation based on sexual practices. When you ask questions, make sure there's a reason underlying the question. What is that factoid of information going to help you elucidate in terms of risk factor for disease, diagnosis, or treatment?
Whenever your motivation for the question is clear, you will never be faulted for having asked that question. All right. So this is a very, very quick snapshot of the health inequities. Hopefully, at the end of today, you have a better understanding of how the developmental challenges of LGBT youth result in health inequities in adulthood. The earlier we intervene, the more likely we are to prevent these health inequities in our gay or lesbian patients. We have a few minutes left. You've been very attentive. I'd be happy to answer any questions. Yes?
When, at the beginning of your lecture, you talked about helping youth, is there a set of guidelines for like how to talk to parents about these sorts of issues and how to be a supportive role for the child that might be in?
So there are two sets of guidelines, depending, I'm not walking away from you, I'm walking away from whatever's making me think that's out. So there are two sets of guidelines. There are guidelines from the Academy of Child and Adolescent Psychiatry, and there are also guidelines from pediatricians who have guidelines for youth who are struggling with same-sex arousal and their parents. And then there are specific guidelines that were just released in the last year about gender dysphoria, or youth that struggle about their gender identity. When you're treating children, you always have to remember that you're treating a system. If you just talk to the adolescent but not to the parent, all the good that you do with the adolescent will be undone if the parent is not on board with you. So you must always talk to the adolescent. Well, you talk to both of them, parent and child together, but then you must also talk to the child by himself or herself, and then to the parent as well. Ultimately, you have to remind the parent to allow the child to make their decisions at their own rate themselves. You have to remind the child that even if he or she lives in an environment that is potentially very adverse or antagonistic, you should encourage the child to seek social support elsewhere outside of the family. Gay-straight alliance, youth group. That's how you help the child buffer the adversity from the parent, but you also need to tell the parents that there are resources for them. For example, PFLAG is Parents and Friends of Gays and Lesbians. They can look at the online resources, they can call, there are local chapters everywhere. That's essentially, and whether we're talking about gender identity or sexual orientation, those are the general guidelines. You have to cater to the needs of both. I don't know if that answers your question. Yes?
Maya had mentioned that they now have drugs that will basically stop puberty, so they have longer to decide. Is that something that the parent has to consent to?
Yes. So GnRH antagonists are being used. This is relatively new in the past few years. Boston Children's does it. And Children's in Philadelphia is going to, because they're going to come up with a gender identity center. It is a lot easier to help someone transition if they don't have to undo the sexual differentiation of adolescence. So if you give a GnRH antagonist and you block the secondary sexual characteristics, then it will be easier to allow the person to live in a body that conforms with their gender identity. Parents have to consent. You cannot treat a child unless the parent consents. So the ethics committee of Boston Children is always called in when there's a discordance between parent and child, and often what happens is that they will meet either to the age of 14 or 16, depending on where you live in the country and what the actual issue is, that you must have parental consent. Yes?
What kind of side effects are associated with that medication? Because to me that just sounds like a really scary idea, like putting people on medication to stop puberty, essentially. I'm just wondering what adverse effects that have.
Actually, very little adverse effects, other than the psychosocial stuff. Like your gut reaction to it is like, that sounds scary. That's the adverse effect of GnRH antagonists. They're fairly benign because they just block. They don't create a biological process. They just block a biological process so that it's different. That's why side effect profile is relatively benign. The most important thing is if you give that medication without any mental health support or counseling, then you have side effects because people will not react
very well. If you treat a young person without support from the family or the parent, that's when you get side effects. But it's interesting, what you shared with us about your gut reaction to it is, that's why it has taken a long, long time. We've known about GnRH antagonists for a while now, but only in the past few years have we decided that ethically it was okay. So the bioethics people got together and thought about it and finally said, well, it's reversible, and it's just putting something on hold, and the advantages of doing that outweigh the risks. So having someone's adolescence be delayed so that they can then choose the right body that conforms with their gender outweighs any risks of, okay, someone will have a delayed adolescence if something goes wrong down the road. Yes?
Those medications have a lot of side effects in adults, right? Is it just because they haven't gone through puberty yet, that they're not having side
So you can give GnRH antagonists to adults. We would only give them to people who are pre-pubertal. So GnRH is gonadotropin releasing hormone. So once you've been, sorry, I don't know what I did, but I apologize. So you cannot, once the gonadotropin releasing hormone has had its effect and there's been secondary sexual differentiation, there's no point giving it. You would only give it to pre-pubertal people, so 7, 8, 9, 10. Actually, I'm not sure what would happen if we gave it to an adult. I'm thinking nothing, because you cannot undo secondary sexual characteristics. Yes.
How long does the child usually, or how long can the child stay on those for?
Typically, a decision is made around the age of 16 or so. Actually, I don't know how long potentially. Like, could you be on it forever? I don't think that anybody wants to, because ultimately you do that because there's something you're doing it for, right? Because you will want to transition. I actually am not sure what would happen if you did it forever, other than it's impractical and would likely not happen. But there's always an end game. So you start at 8, and by the age of like 15 or something, then you're going to start taking gender-conforming hormones. Yes?
I'm guessing it's unlikely, but what if we had a young adult patient who makes it known to us that they're homosexual, and they want us to tell their parents, because they haven't done so already?
So define young adult. Because it depends how old, right? Because the NIH says that adolescence ends at 24. I'm sure you all disagree, but the NIH, if you want to enroll someone in an adolescent trial of anything, you can enroll up until the age of 24. So that's why I'm asking you the trial there.
Let's say 14.
Okay. So then ultimately, you always want to give your patients tools to allow them to achieve positive health. In a situation like that, where you may want to say, well, maybe we can do it together. Like, I can be there with you, and we can have this discussion with your parents, and I can be there to buffer you to make sure that everything goes okay, and answer some questions your parents may have. Then you have your own personal cutoff, but there's a point where you would not do that because you're kind of infantilizing a person. Like, at one point you have to say, well, you know, why don't we have a timeline? Why don't we role play, you and I? You can practice telling me, I'll pretend I'm your dad, and then we can role play some potential answers, and then they do it on their own. Or if that person is still afraid, so let's say it's going to be like a 20-year-old, like I wouldn't have a 20-year-old come to my office and tell their parents. I would say, well, why don't you identify friends? Like, who's part of your inner circle? Who are the people that you trust would be your allies? Why don't you have them be present with you when you tell your parents? And don't just call them and leave a message on the answer machine. Or also add that in there. Yes?
I'm wondering, what is the average age that a transgender person begins to transform? And also, is there any sort of medical consensus or controversy if there's too young an age to do so?
So definitely controversy. Not everybody agrees, and they have even shared with us the guidelines for transitioning. Not everyone within the transgender community agrees with these guidelines because they make some impositions, and it's like, you know, straight cisgender people that have made guidelines about transgender individuals. It's like men deciding about women's contraception. Like, it just doesn't make sense. So these guidelines are going to continue to evolve. As far as age, I don't know how to answer that for you, because if we look at, like, this is like one of the new frontiers for tomorrow's doctors, but all we have to do with currently are retrospective data, people that have transitioned much, much later, people that were married, had children and transitioned after that, because it was a time and a place that was more permissive for them. Now we're talking about it more. Now you will see a 10-year-old and you will see a 12-year-old. I don't know what the current normative ages are. All we know is that usually by the age of 3, sex roles are determined, and from 3 to 12, gender roles are required culturally. Where transgendered individuals fit in that spectrum is not clear to me. But the one word of caution is, so let's say we come out with numbers, right? Like it's by 7 and by 12. It conveys the false message that everybody follows the same journey, and if we learned anything today from our 2 panelists, is that it is nothing could be further from the truth. So that's the most honest answer I can give. One last question before we break. Yes.
I have a sort of naive question about semantics.
Yeah.
When addressing a transgendered individual, what sort of pronouns should I be using? I would assume that I would ask the individual what they feel comfortable with.
That's it. That's your question. Remember that you will never know everything, and when in doubt, ask. And you answered your own question for us. If you are unsure what pronouns to use, ask your patient, how would you like me to address you? Are there words you feel more comfortable with? Are there words I should avoid? You will never, ever go wrong if you do that. It's never good to be a hero and to think you know everything. You should always remember to be humble, and it's about them. Let them tell you what they want.